Welcome back to the Deep Dive. Today we're embarking on a journey into a field that, well, it touches countless lives, often in really surprising ways. When many of us hear plastic surgery, a certain image comes to mind, maybe, something purely cosmetic. But our sources for this deep dive, specifically excerpts from Sanderson's textbook of surgery, reveal a much broader, much more profound reality. Our mission today is to unearth the incredible innovations and the sheer breadth of plastic surgery. We're exploring how it goes far beyond what you might imagine, truly aiming to restore, repair, and make whole.
Wow.
And as we'll uncover today, this isn't just about aesthetics. It's about pioneering techniques that are fundamentally changing lives, often in ways you might never expect.
Indeed, it's a specialty challenged by really complex clinical problems. And the pace of innovation, it's accelerated steadily over the past 3 decades.
Wow, 3 decades.
Yeah. What's truly fascinating here is its unique position. It benefits from, well, the absence of strict anatomic or organ system boundaries.
So less siloed than other specialties.
Exactly. This fosters deep collaboration with other surgical specialists, continuously pushing the boundaries of medical progress across the entire body.
So you might think you know plastic surgery, but get ready for a deep dive into its true scope and impact.
Yeah.
Okay, let's unpack this then. Our sources immediately challenge the common perception. Plastic surgeons aren't confined to a single area. They're truly problem solvers across the entire human body, involved in, well, a surprisingly vast array of medical interventions.
That's right. It's a relatively small specialty, yet its practitioners have to stay acutely aware of innovations across a huge array of medical areas.
Like what sort of areas?
Think about the incredible range, from highly specialized surgery for congenital abnormalities, conditions people are born with, like clefts or skull deformities, to maxillofacial surgery, dealing with the complex structures of the face and jaws.
Right.
Then there's breast surgery, which extends far beyond augmentation into reduction and vital reconstruction. And hand surgery, restoring intricate function to one of our most used body parts. They also handle head and neck surgery, complex skin and soft tissue defects, aesthetic surgery, of course, and body contouring for significant shape changes, especially after massive weight loss.
That's a huge area now.
It is. And beyond that, they are experts in wound care, often dealing with the most challenging non-healing wounds. They utilize advanced microsurgery techniques, which we'll definitely dig into. Plus, they play a critical role in burn care, a field demanding extensive reconstructive expertise. The unique solutions plastic surgeons develop in these diverse areas, that's precisely what sustains the field's momentum of innovation.
It's almost like they're the ultimate adaptable repair crew for the human body, always inventing new ways to solve old or even newly emerging problems. It really redefines what plastic surgery means, doesn't it? Not just plastic as in moldable, but plastic as in, adaptable and comprehensive.
That's a great way to put it. Adaptable is key.
Okay, so for centuries, reconstructive surgery followed a kind of ladder. Starting simple, only getting complex if absolutely necessary. Our source introduces this reconstructive ladder concept. It guides surgeons from direct closure to skin grafts, then local flaps, distant flaps, and finally, the most complex stuff, microvascular free tissue transfer. A very sequential, step-by-step approach.
The traditional ladder did prioritize the least complex option first, almost like a default setting. However, modern plastic surgery defines the basis for setting reconstructive goals as a triad: form, function, and safety.
Form, function, safety.
Right. This means a surgeon isn't just trying to cover a defect. They're aiming to achieve the best possible aesthetic and functional outcome while always ensuring patient safety. For example, in facial reconstruction, restoring an area with skin of the exact same thickness, texture, and color might demand a more complex technique, like tissue expansion, over a simple skin graft.
Even though the graft is lower on that ladder.
Exactly. Even though tissue expansion is higher on the ladder, it provides a superior match and outcome for that specific defect. So it becomes the preferred choice, despite its complexity.
Okay, here's where it gets really interesting for me. The source talks about a shift from this ladder to a reconstructive elevator. What does that mean for the patient? How does it change the decision making?
It emphasizes selecting the most appropriate level of reconstruction rather than automatically defaulting to the least complex.
So skipping steps on the ladder.
Kind of. Instead of strictly climbing step by step, the elevator allows the surgeon to directly choose the optimal technique from any floor of the reconstructive spectrum. It's about achieving the best possible outcome for the patient's specific defect, considering, again, form, function, and safety.
So,
Even if that means taking the elevator straight to a more advanced technique like a free flap or tissue expansion, rather than trying simpler options first that might not be ideal.
right, choosing the best tool for the job from the start.
Precisely. This demonstrates the growing sophistication and really the patient-centered approach in modern plastic surgery. It means greater precision and often better long-term results for individuals facing complex reconstructive needs.
Let's start with the absolute basics then. How wounds are closed, what makes a good closure technique in plastic surgery, and why is that initial step so important for the final look?
Well, it begins with meticulous precision right from the very start. This means making an incision with the scalpel held at right angles to the skin, ensuring clean, straight edges.
Okay.
Then it's about really careful tissue handling to avoid devitalizing the wound margins, which can impede healing. If necessary, debridement of the skin edges removes any non-viable tissue. Crucially, the wound margins must be averted, slightly turned outwards, and then precisely approximated without tension.
Averted, okay. Why outwards?
So the skin edges line up perfectly level, just touching. It prevents a depressed scar later on. And minimizing tension is absolutely essential to reduce scarring.
How do they manage that tension?
A couple of ways. First, by using buried deep dermal and subdermal sutures. These take the load off the superficial skin sutures. Second, and equally important, is aligning skin incisions along what we call relaxed skin tension lines.
Natural wrinkle lines.
Exactly. Natural skin lines, wrinkle lines, lines of facial expression. These lines run perpendicular to the underlying muscles. When a closure is placed along one of these lines, it's under minimal tension and heals with significantly less scarring.
So there's a real art to the initial cut and stitch. It's not just sewing it up.
Definitely not.
But what about those wounds that can't be closed immediately? Maybe they're too large, too complex, or infected.
That's where negative pressure wound therapy, or NPWT, comes in. It's a technology developed back in the early 90s, and it's really expanded options for managing complex wounds that can't be immediately closed.
NPWT.
Yeah.
How does that work?
Its application has been shown to be incredibly beneficial. It increases the rate of granulation tissue formation, that healthy red tissue you need for healing. It decreases edema or swelling. It reduces how often dressings need changing, which is good for patients. It can sort of buy time, allowing for better wound bed preparation before definitive closure. Importantly, it helps control bacterial colonization in the wound.
So it's like a bridge therapy.
Exactly. It's commonly used as a bridge, preparing and creating a more viable, healthy wound bed, often before placing a skin graft.
Okay, let's talk about skin grafts then. Moving skin from one part of the body to another. What does that piece of skin need to actually survive once it's moved? It doesn't have its original blood supply anymore.
Right, a skin graft is exactly that. A segment of dermis and epidermis completely separated from its original blood supply. Its survival absolutely requires a vascularized recipient bed.
So the new spot needs good blood flow.
Absolutely. Good, healthy beds include things like healthy soft tissues, periosteum, perichondrium, peritoneum, even bone surfaces if they're prepared correctly to encourage granulation tissue. Conversely, poor wound surfaces where a graft is unlikely to take include exposed bone without its covering, cartilage, tendon, implants, or really fibrotic chronic granulation tissue. And the wound must be completely free of infection and debris. Those act as a barrier, preventing the graft from getting the blood supply it needs.
So it's not just about getting skin to stick. It's about the right kind of skin for the job. What's the fundamental difference between a split thickness and a full thickness graft? What's the trade-off?
The key really lies in balancing the size of the wound with the desired outcome, both aesthetic and functional. Split thickness grafts are like a versatile patch for larger areas. They're just the epidermis and a portion of the dermis.
Thinner.
Yes, thinner. They're harvested with a dermatome, and you can even mesh them, cut slits, and expand them, which is great when donor skin is scarce or the area is uneven, and their donor sites heal quickly on their own.
But there's a downside.
There are compromises. They can contract over time, which can be a problem functionally. They might have abnormal pigmentation, not matching the surrounding skin perfectly, and they're generally less durable.
Okay, so what about full thickness grafts?
Full thickness grafts include the entire dermis, along with hair follicles and glands. They're removed with a scalpel, and because the donor site has to be sutured closed, they're necessarily smaller. These are the premium choice for a near-perfect match, especially in visible areas like the face. They look and feel more like normal skin, they can grow hair, secrete sebum, and are more durable.
But they sound harder to work with.
Their greater thickness means their take is a bit less predictable because more tissue needs revascularization. And you're limited by where you can harvest them from usually thin-skin areas like eyelids or behind the ear. So the insight is always matching the tool to the specific need, not just patching a hole.
That's fascinating how the body just integrates this new tissue. How does a skin graft actually take? How does it become a living part of the body?
The take happens in three pretty distinct phases. First, for the initial 48 hours or so, there's what we call plasmatic circulation. The graft is basically nourished by plasma fluid seeping from the host bed, kind of like a sponge soaking it up.
Okay, so it's surviving on diffusion initially.
Right. Then, after about 48 hours, revascularization begins. This is critical. New blood vessels start growing into the graft from the bed, and existing tiny vessels in the graft and the bed actually link up a process called inosculation.
Wow, they actually connect.
They do. And finally, organization starts almost immediately. A fibrin layer, like a natural glue, holds the graft in place initially. This is then gradually replaced by fibroblasts, the cells that build connective tissue, around day 7. Grafts are pretty securely attached within 10 to 14 days. Sensation returns gradually, with pain first, then light touch and temperature over many months.
What can go wrong? What makes a graft fail?
The most common cause of failure, by far, is a hematoma, a collection of blood forming underneath the graft. It acts as a physical barrier, preventing that crucial revascularization.
Makes sense. Anything else?
Shearing forces or movement can disrupt those delicate new vessel connections. Infection is another big one. Or simply having a poor quality recipient bed without enough blood supply. Even characteristics of the graft itself, like its thickness, can play a role.
So how do surgeons try to prevent these failures?
Dressings are key. Usually light pressure dressings or bolsters are used, often left undisturbed for 4 to 5 days, to keep the graft pressed firmly against the bed and prevent fluid buildup. Negative pressure wound therapy, that NPWT we mentioned, can also be really effective in stabilizing grafts, especially on larger or irregular surfaces.
What about things like lab-grown skin?
Tissue-cultured skin cells are used, particularly for extensive burns where donor sites are very limited. But they come with challenges. They tend to be more fragile and more susceptible to infection, take time to cultivate in the lab, and there are some theoretical concerns about long-term risks from substances used in their culture.
Okay, so grafts are one way. But what if, instead of transplanting from another site, you could just grow more skin right where you need it? This brings us to tissue expansion. Sounds almost like science fiction.
It does, doesn't it? But it's a well-established technique. Tissue expansion uses a mechanical stimulus stretching to induce new tissue growth for reconstruction. Basically, a prosthesis, an expander, which is like a deflated balloon, is placed under the skin near the defect. Then, it's gradually enlarged over time by injecting saline into a port.
So you're literally stretching the skin.
Initially, yes. The first effect is stretching, forcing out interstitial fluid, fragmenting elastic fibers. But over time, this sustained tension actually triggers biological processes that lead to actual growth of the skin flap. You get increases in collagen and ground substance. Histologically, you see the dermis thins a bit, the epidermis thickens, but crucially, skin appendages like hair follicles and glands are generally unaffected.
That's incredible. It's like tricking the body into making more skin. But are there limits? Can you do this anywhere?
There are limitations. The tissue itself must have the capacity for growth. Prior irradiation or significant scar formation can impede or even prevent successful expansion.
Makes sense. The tissue has to be healthy enough.
Right. Expanders also perform poorly under existing skin grafts, in very tight tissue, like the lower leg sometimes, and generally not well in the hands and feet where there's little loose skin to begin with. And there are definite contraindications. You wouldn't expand near a malignant neoplasm, a hemangioma, or an open leg wound, for instance. The expanders themselves come in various shapes and sizes, tailored to the defect, and the injection ports can be remote or integrated right into the expander.
How does the process actually work for the patient? Walk us through it.
Okay. The expander is ideally placed under tissue that best matches the tissue that was lost in terms of color, texture, hair-bearing qualities. Surgeons are very careful to avoid distorting nearby landmarks like the eyebrow or the hairline during expansion. The incision to insert it is often placed strategically where it will be excised later during the reconstruction. A common reason for failure, actually, is constructing a pocket that's just too small for the device initially.
And the filling process.
Filling typically starts about 2 weeks after the initial surgery, once things have settled down. Then it continues, usually weekly or biweekly, guided by the patient's pain threshold and how tight the skin feels. The second surgical procedure, the reconstruction itself, happens when enough expanded tissue has been generated to produce the desired effect, essentially covering the defect. If not enough tissue is generated in the first round, sometimes a second round of expansion can be done. And the advantages here are really significant. You're providing perfectly matching tissue for the reconstruction. The transferred tissue has normal sensibility. There's a negligible donor defect because you grew the tissue nearby. And interestingly, pre-expansion can even enhance the success of traditional flaps by augmenting their vascularity.
What are the trade-offs then? It sounds amazing, but there must be some disadvantages.
A key disadvantage, particularly if you're thinking of pre-expanding a free flap, is the time commitment. The expansion process takes weeks, sometimes months. That delay might simply not be acceptable for urgent situations like oncologic defects or complex infected wounds. Additionally, pre-expanded free flap procedures can actually be technically more difficult for the surgeon because the expansion process can distort the vascular pedicle, making the microsurgery trickier.
Okay, so moving beyond the body's own tissues, plastic surgery also incorporates synthetic materials. What exactly are alloplastic materials and what are their main benefits?
An alloplastic material is simply a synthetic substance implanted into living tissue. Its primary advantages are, 1, availability. They're there when autologous or the patient's own tissue isn't sufficient or suitable. And 2, the absence of donor site morbidity, no extra scars or problems from harvesting tissue elsewhere.
And they last.
Unlike bone or cartilage grafts, which can resorb over time, non-biodegradable alloplastics don't undergo resorption, offering permanence. Plus, they can be manufactured for very specific needs, like controlled-release drug delivery systems.
What's the body's typical reaction? Does it just accept these foreign materials?
The tissue response varies significantly depending on the material's chemical composition, its microstructure, and its macrostructure, how it's shaped. For instance, polypropylene mesh used in hernia repair is designed to encourage vigorous tissue ingrowth for strong support. But a silicone tendon prosthesis aims for the opposite, promoting a smooth, fibrous capsule for free gliding. However, all implants share common requirements. They absolutely must be non-carcinogenic, non-toxic, non-allergenic, and non-immunogenic. And there are always underlying concerns about mechanical reliability and long-term biocompatibility.
So you mentioned composition is key. How are these materials generally categorized?
Probably the most useful classification is by their chemical composition. First, you have metals. Clinical use includes stainless steel, vitalium, a cobalt-chromium alloy, and titanium. They need mechanical strength, the right elasticity, and strong corrosion resistance. Corrosion is a major concern, as metal ions leaching out can cause inflammation, pain, allergic reactions, and loosening.
Okay, metals. What else?
Second, ceramics. These are highly stable and chemically resistant materials, including things like hydroxyapatite. This material can actually bond strongly to adjacent bone, a process called osseointegration, making it useful for facial skeleton augmentation or as a bone graft substitute.
Interesting. And the third category?
That's polymers. These are large, long-chain macromolecules, essentially complex plastics. Their huge use in surgery is due to their ease and low cost of fabrication, and how easily they can be processed into various forms, tubes, fibers, meshes, films, foams, you name it. Most surgical polymers are relatively inert, stimulating a simple fibrous encapsulation. Their physical form, solid versus mesh, smooth versus rough, determines how the tissue encapsulates them. Chemical composition, how much they like water, their charge, and durability also influence the reaction. Silicone rubber, PTFE, Dacron are stable. Nylon degrades over time.
And you mentioned biologic materials separately.
Right. Biologic materials, like collagen, are technically polymers, but often classified separately because they're derived from biological sources. This introduces potential protein antigenicity, meaning the body's immune system might react, which adds another layer of consideration.
Okay, so we've covered direct closure, grafts, tissue expansion, and synthetic materials. But how do surgeons move larger, more complex pieces of tissue around while keeping them alive? This brings us to flaps, right? The cornerstone of reconstructive surgery.
Exactly. A flap is tissue that's moved from one part of the body to another while maintaining its own vascular pedicle, its own dedicated blood supply.
So it stays connected, in a way.
It does. That pedicle can either remain physically intact, just stretched or rotated, or it can be surgically divided and then meticulously reconnected to blood vessels at the recipient site using microvascular anastomosis. That's a free flap. This preserved blood supply makes flaps generally more robust and reliable than grafts, especially for complex defects or compromised wound beds.
And how are these flaps classified? There must be different types.
They're primarily classified by three basic characteristics. First, composition. What kind of tissue is in the flap? Is it just skin, cutaneous, muscle and skin, musculocutaneous, fascia, skin, bone and skin, osteocutaneous, or even sensory nerves? Second, method of movement. How is it transferred? Is it a local flap, just moved adjacent to the defect? A distant pedicle flap, brought from further away but still attached? Or a microvascular free flap, completely detached and reconnected? And third, critically, it's blood supply. Arteries reach the skin mainly in two ways. Through muscle, musculocutaneous arteries, or between muscles, subcutaneous arteries. A flap can have a random pattern relying on the diffuse dermal plexus, or an axial pattern specifically designed around a named vessel, which allows for greater length and reliability.
Let's start with local flaps then. Sounds like using tissue right next door. What are the big advantages there?
Exactly. Local flaps utilize tissue immediately adjacent to the defect. This is a huge advantage because it usually matches the recipient's site perfectly: color, texture, hair growth, thickness. That's crucial for good aesthetic and functional results, especially in highly visible areas like the face.
And donor site.
Often they can be designed so the donor site where the flap came from can be closed directly, minimizing additional scarring. These flaps rely heavily on the skin's natural elasticity, which makes them particularly useful in older patients whose skin tends to be looser. Sometimes, though, the donor site might need a skin graft itself if it's too large to close directly.
What are some common types, and what's the main risks surgeons need to watch out for with these?
Common types include rotation flaps, transposition flaps, and advancement flaps, different geometries for moving the tissue. By definition, these are often random flaps, meaning their blood supply relies solely on that subdermal plexus rather than incorporating a specific named artery. Because of this, the most common failure is necrosis, or tissue death, of the most distal portion of the transferred tissue, the part furthest from the blood supply.
Why does that happen?
It can happen if the flap is designed too large for its inherent vascular supply to support, or if there's some external mechanical compromise of the pedicle, maybe a hematoma underneath, dressings that are too tight, or twisting or kinking of the base. So proper flap design and meticulous handling to avoid these extrinsic pressures are absolutely key for viability.
Okay, moving up in complexity. Muscle flaps. They sound like a powerful option for the robust blood supply. But muscles have jobs to do. How do surgeons decide if a muscle can be used for a flap without causing major functional problems?
That's a critical consideration. The feasibility comes from the muscle's independent, intrinsic blood supply. Surgeons classify muscles based on this vascular anatomy. It's like understanding their internal plumbing. Some muscles have a single, strong, dominant pedicle, like a main pipe, that can sustain the entire muscle. Think of the latissimus dorsi in the back, or the gastrocnemius in the calf. These are type I or type V in the classification system we'll use.
So those are reliable choices.
Very reliable. Others might have a dominant pedicle plus some smaller minor ones, type 2, or two dominant pedicles, type 3, or multiple smaller segmental pedicles, type 4. Large muscles with a recognized dominant pedicle, types 1, 3, and V, are generally the most useful because their vascular anatomy is predictable and robust.
And compared to just skin flaps?
Muscle flaps generally have a much more robust blood supply. They perform significantly better in wounds that are compromised, maybe by previous irradiation or active infection. Their vascular anatomy is usually quite predictable. And sometimes a muscle can even be used as a functional unit for dynamic tissue transfer, like restoring facial animation.
It's incredible to think about moving a whole muscle. But that immediately brings up the donor site question again. What's the functional impact for the patient, and how do surgeons balance that?
That is a major consideration, always. Surgeons are constantly weighing the benefit of the reconstruction against the potential donor site morbidity, the functional loss. There have been efforts to limit that functional loss. For instance, sometimes muscles can be split into segments if each segment has a different dominant blood supply, allowing a portion to be transferred while preserving some muscle function at the donor site. Now, a musculocutaneous flap, sometimes called a myocutaneous flap, takes this a step further. It's a muscle flap designed with an attached paddle of overlying skin.
How does the skin stay alive?
Each superficial skeletal muscle carries blood supply to the overlying skin via perforating blood vessels, either musculocutaneous perforators going through the muscle or subcutaneous perforators running between muscles. The number and pattern vary, so the potential skin territory differs for each muscle. We've learned a lot about these territories from anatomical studies and clinical experience.
And this leads directly to the next big evolution, right? The perforator flaps.
Exactly. The crucial insight was realizing that these source vessels branch within the muscle, perforate the deep fascia covering the muscle, and then nourish the skin. Critically, these perforating muscular branches can often be meticulously dissected out of the muscle substance without jeopardizing the perfusion of the skin paddle. This intramuscular dissection separates the perforators from the muscle itself. That forms the basis for perforator flaps. It means the muscle itself becomes unnecessary for the survival of the skin paddle. Its inclusion becomes, in a sense, passive, mainly done historically to avoid that tedious dissection. This has led to a huge growth in the number and types of perforator flaps used, like the DEP flap, deep inferior epigastric perforator for breast reconstruction, which spares the rectus abdominis muscle, significantly reducing abdominal wall complications compared to the older tram flap, which took the muscle.
What's fascinating here is how this deep understanding of skin circulation just keeps evolving, leading to even more refined techniques. Where do fasciocutaneous flaps fit into this picture?
Well, as our knowledge about musculocutaneous circulation grew, surgeons also identified vascular pedicles emerging between muscles. These travel within the intermuscular septum, the connective tissue partition, and enter the deep fascia. These are termed septocutaneous perforators.
Not through the muscle, but around it.
Exactly. And these supply the fascial plexus, which is a network of vessels within the fascia itself. This plexus, in turn, gives off branches to nourish an overlying territory of skin. The source material mentions the concept of an angiosome, which is like a 3D block of tissue supplied by a single source artery. The entire body surface is composed of these interconnected units. These fascial feeder vessels terminate within the fascial plexus itself.
So it's about leveraging these intricate, interconnected networks within the fascia. Does that mean we're seeing more possibilities now, especially in tricky areas?
Precisely. The concept really arose from surgeons observing that skin flap size could be increased if they were oriented along the long axis of an extremity and, crucially, included the deep fascia in the flap. Anatomical studies then confirmed the existence of these septocutaneous pedicles, supplying a regional fascial vascular system. Larger septocutaneous pedicles are fairly constant anatomically, which has led to the development of widely used specific fasciocutaneous flaps like the anterior lateral thigh flap, the radial forearm flap, and the lateral arm flap.
Are there challenges in designing these flaps?
Yes, their design has largely been learned through clinical experience, and their absolute limits are still being explored. There aren't always hard and fast rules because these deep fascial perforators can be quite variable in their size and exact location, even between the left and right sides of the same person. Often, the expected size range of a particular flap is learned through the shared experience of other surgeons.
What's a particularly useful feature of these fasciocutaneous flaps?
One of their most useful features is that they can often be distally based. Unlike many muscle flaps, where the dominant blood supply typically enters closer to the heart, the blood flow within the fascial plexus is often multidirectional. This means a flap pedicle can sometimes be based on vessels further down the limb, distally, and still support a reliable skin territory. This flap can then be transposed to cover a defect located even further towards the end of the extremity.
Can you give an example?
Sure. The distal-based sural artery flap uses skin from the calf, based on a distal perforator from the peroneal artery, and can be transferred down to cover defects on the foot and ankle. This often avoids the need for a more complex free microvascular transfer. Other advantages include the ability to potentially confer sensibility if a sensory nerve running with the fascia is included in the flap. And compared to musculocutaneous flaps, they don't sacrifice functioning muscle, and the fascia is more accessible. However, the anatomic anomalies in the fascial system and the still somewhat unanswered question of their effectiveness in irradiated or infected wounds are comparative disadvantages.
This raises an important question. If we can spare the muscle, like with perforator flaps, or even spare the underlying fascia by using these septocutaneous vessels, and just take the blood supply, what does that open up?
That is the very essence of perforator flaps, building on both musculocutaneous and fasciocutaneous principles. They evolved as a refinement, demonstrating that neither a passive muscle carrier nor the underlying fascial plexus is strictly necessary for flap survival, provided the specific musculocutaneous or fasciocutaneous vessel supplying the skin is carefully dissected out and preserved.
What are the big benefits here? It sounds like you're minimizing donor site damage even further, which must be huge for patients.
The advantages are significant, yes. Primarily, the preservation of functional muscle and fascia at the donor site, which greatly minimizes morbidity. And tremendous versatility in flap design surgeons can include as little or as much bulk tissue as the specific reconstruction requires. However, there are disadvantages. The dissection required to isolate these often tiny perforator vessels is technically difficult and can be very time-consuming, leading to longer operating times.
And they're variable.
Exactly. There's anatomical variability in their position and size. The pedicles can sometimes be short, limiting reach, and the vessels themselves are small and fragile. Remember, a perforator is technically defined as a blood vessel that passes through the deep fascia and contributes blood supply to that fascial plexus, originating from a deeper source or mother vessel.
How do surgeons even find and work with these tiny variable vessels during surgery?
Because of their small size and variability, handheld Doppler ultrasound is routinely used before surgery to try and locate suitable perforators. However, it's not perfectly accurate, meaning clinical experience and judgment remain absolutely crucial during the actual flap elevation. Technical recommendations for harvesting include trying to identify at least one vessel with a diameter of 0.5 millimeters or more, ideally including 2 or more perforators in the flap if possible, ensuring sufficient pedicle length for transfer, and always preserving a subcutaneous vein for venous outflow, just in case the deep venous system proves anomalous.
What's next for perforator flaps? How is this precise technology continuing to push the boundaries?
Oh, the use of perforator flaps is definitely still evolving rapidly. Current work includes techniques for flap thinning, where excess adipose tissue is meticulously removed from the flap as it's being raised. This can provide large, yet very delicate segments of vascularized skin, ideal for contour-important reconstructions like the ear. Another really exciting innovation is the discovery and use of new flaps based on even smaller perforators, less than 0.8 millimeters in diameter, found superficial to the fascial plane.
Above the fascia.
Yes. This potentially eliminates the need for any deep intramuscular dissection at all, which could shorten operating time significantly and further expand the number of potential flap donor sites. The main challenge with these so-called superfascial free flaps is the need for supermicrosurgery to perform the anastomoses, the connections, in such incredibly tiny vessels.
Okay, when we talk about custom-tailored solutions, microvascular free tissue transfer or free flaps sound like the ultimate expression of that. Yeah. What exactly is involved in these incredibly complex procedures? They sound like a huge undertaking.
They are. Microvascular free tissue transfer involves transplanting distant tissue, could be skin, fat, muscle, cartilage, bone, nerve, even bowel or omentum, along with its own arterial and venous blood supply from one part of the body to another. Once moved, its vessels are then meticulously anastomosed or reconnected to recipient vessels at the new site using microsurgical techniques.
And the choice of tissue.
It depends entirely on the defect's needs. What size is it? What composition is required? Soft tissue coverage, structural support, function. Then there are technical considerations like the size of the vessels available in the donor tissue and the required length of the vascular pedicle. And of course, the potential donor site deformity that harvesting the tissue will create.
This sounds incredibly complex, requiring immense planning and precision. What about the timing and the preparation needed? Tissue can't survive long without blood flow.
You're right. Preoperative planning is absolutely paramount. It starts with careful patient selection and a thorough analysis of the defect. Environmental factors are key. Has the recipient site had previous surgery or radiation? That can impair tissue and vessel quality, sometimes necessitating imaging like angiography beforehand. And yes, there are critical ischemia times, the time the tissue can survive without blood flow. Muscle tolerates about 2 hours, while skin and fasciocutaneous flaps might tolerate 4 to 6 hours. Meticulous planning and efficient teamwork are the most important factors to minimize this ischemia time.
So everything has to be ready.
Exactly. All structures at the recipient site must be prepared before the donor pedicle is divided. Sound technique requires healthy recipient vessels of a reasonable size with good outflow, and the anastomosis, the connection, must be absolutely tension-free. This might mean mobilizing the recipient vessels to gain extra length. Vein grafts can be used if needed, but they're not the first choice as they tend to reduce success rates slightly. Interestingly, both end-to-end and end-to-side arterial anastomoses have similar patency rates. End-to-side is often preferred if there's a significant size mismatch between the vessels or if the recipient artery's continuity needs to be preserved. Vasospasm, a common issue caused by manipulating these tiny vessels, can be relieved with topical medications like lidocaine or piperine, or sometimes by stripping the outer layer of the vessel, the adventitia, to remove nerve fibers.
What happens after the surgery? How do you know the flap is surviving moment to moment, especially in those critical early hours?
Postoperative monitoring is absolutely critical. Rapid identification of ischemia or lack of blood flow allows for immediate intervention and often flap salvage. Most free flap thromboses, blood clots blocking the vessels, occur within the first 48 hours. Prompt intervention during this window leads to high salvage rates. Clinical evaluation involves observing the flap's skin color, capillary refill time, its fullness or turgor, and the color of any capillary bleeding if you prick it. For flaps that are buried under the skin, sometimes a temporary monitor island of skin is left exposed, or an implantable monitoring device can be used things like temperature probes, pulse oximetry, photoplethysmography, or Doppler probes listening for blood flow.
The source says tissue survival rates exceed 98%, which is just remarkable for procedures this complex. But also mentions re-exploration rates can range from 6% up to 25%. What causes surgeons to have to go back to the operating room?
It is remarkable, a testament to the refinement of techniques. The most common reason for re-exploration is thrombosis, a clot, usually of the arterial anastomosis. This can be primary thrombosis, often due to technical faults during the initial surgery, maybe a narrowed lumen, sutures tied to loosely exposing vessel layers that promote clotting, sutures tied to tightly tearing the vessel, too many sutures causing damage, or inadvertently catching the back wall of the vessel, obstructing flow.
Okay, so technical issues. What else?
Then there's secondary thrombosis, which refers to kinking or external compression of the vessels, perhaps by a hematoma or significant swelling, which leads to decreased inflow. But as I said, with prompt re-exploration, the salvage rates, the chances of saving the flap are generally quite good, varying from maybe 54% up to 100% in some series. And the field is constantly refining. A current emphasis is on identifying transfers that better suit the recipient site while minimizing donor site problems. This has spurred minimally invasive and endoscopic harvesting techniques and fueled the development of perforator flaps and those superfascial free flaps we talked about.
This is where the future gets even smaller, literally. You mentioned supermicrosurgery earlier. How incredibly small are we talking about when it comes to the vessels being reconnected?
The introduction of supermicrosurgery has truly revolutionized reconstructive options by allowing the surgical connection, the anastomosis, of vessels ranging from an astonishing 0.3 to 0.8 millimeters in diameter.
0.3 millimeters, that's tiny.
It's incredibly small, thinner than a standard sewing needle. This level of precision enables entirely new approaches, like transferring free perforator to perforator flaps using those superfascial vessels we discussed. This means they can potentially be transferred more quickly, and the tissue can be obtained from better concealed parts of the body, improving cosmetic outcomes.
So essentially, if there's any identifiable tiny vessel, no matter how small, you can potentially design a flap around it and move it anywhere it's needed.
Precisely. If a discrete perforator, even one of these minute vessels, can be reliably identified anywhere on the body, a flap can theoretically be specifically designed and harvested around it. This concept has been termed a freestyle flap.
Freestyle flap, I like that.
It means the traditional constraints of using only previously described named vascular territories can potentially be disregarded. The donor site can be selected solely on the basis of providing the absolute best possible match for color, contour, and texture at the recipient site. It offers unparalleled customization and potentially superior aesthetic outcomes.
What are the unique challenges that come with this extraordinary level of precision? Working with structures that small must be incredibly demanding.
The main disadvantages are really twofold. First, there's the inherent anatomical variation of these tiny perforators. Finding them reliably and dissecting them out safely can be extremely challenging. Second, and perhaps most significant, is the highly demanding nature of the supermicrosurgical technique itself. This requires using incredibly fine sutures. We're talking 12 velar nylon with needles as small as 30 to 50 micrometers. That necessitates high magnification operating microscopes and, crucially, a highly technically adept and experienced surgeon with specialized training. It's pushing the very limits of surgical dexterity.
Let's shift our focus now to the earliest stage of life, where plastic surgery can make such profound differences. We're talking about congenital abnormalities, conditions present at birth that can really impact a child's development and quality of life.
Absolutely. Pediatric plastic surgery addresses a really wide range of these congenital abnormalities and other conditions that specifically impact a child's growth and development. Often, early and precise intervention is key. For example, craniosynostosis. This is the premature fusion of one or more of a baby's cranial sutures, the fibrous joints between the skull bones. This fusion stops the skull from growing normally and leads to characteristic skull and facial deformities.
And that needs treatment early.
Yes, treatment is indicated to correct the deformity, normalize the head shape, protect the eyes by restoring brow projection, and importantly, minimize the risk of increased intracranial pressure, which can affect brain development. Correction during the first 6 months of life is generally associated with better neurodevelopmental outcomes. Surgical treatment typically involves releasing or excising the fused suture, allowing the cranium to expand and remodel naturally. Resorbable plates are often used now, which has significantly improved outcomes. Another really common and impactful area is cleft lip and palate. These are relatively common congenital anomalies occurring either unilaterally or bilaterally. Most are isolated, but many genetic syndromes also include clefts.
How are these corrected? It sounds complex.
It usually requires a minimum of 3, often 4, major operations performed at specific developmental stages. First is the cleft lip repair, typically done between 3 to 6 months of age. This addresses the defect in the mucosa, the orbicularis oris muscle, and the skin. It's often extending into the nose as well. The goal is to return the existing elements to their normal anatomical position, always keeping future growth in mind. Second is the cleft palate repair, usually performed before 1 year of age, or at least before significant speech development begins. The goals here are achieving normal speech and preventing food regurgitation into the nose. This requires creating a static separation between the oral and nasal cavities and, crucially, achieving dynamic closure of the soft palate during speech. Modern techniques focus on repairing the nasal and oral linings and, critically, reorienting and repairing the abnormally positioned levator veli palatini muddles, which are essential for palate function and speech.
And the third stage?
That's often alveolar bone grafting. This usually uses cancellous bone, typically harvested from the patient's iliac crest, hip bone, to restore bone continuity along the dental arch where the cleft was. This supports erupting teeth or later dental implants, closes any remaining fistulas between the nose and mouth, and provides support for the base of the nose. Further surgeries might be needed later, like rhinoplasty or lip revisions in the teenage years.
It's clear that these are incredibly intricate procedures, requiring long-term planning and care.
They are, and a critical point for these complex craniofacial anomalies, like clefts or craniosynostosis, is that the current standard of care is comprehensive team care at an established craniofacial center.
Why is that team approach so important?
It provides a coordinated approach from birth right through adulthood. It brings together plastic surgeons, neurosurgeons, oral surgeons, orthodontists, speech pathologists, otolaryngologists, ophthalmologists, social workers, pediatricians, everyone needed to address all facets of the child's physical and psychosocial development. This integrated approach ensures the best possible long-term outcomes.
Moving to the head and neck in general. This area is so critical for identity, communication, basic functions like eating, breathing, seeing. How does plastic surgery tackle trauma and reconstruction here?
Well, maxillofacial trauma injuries to the face and jaws, while actually decreasing a bit in frequency in the U.S. thanks to things like seatbelt laws and safer cars, still remains a significant part of multi-system trauma from accidents, assaults, and unfortunately combat injuries. Interestingly, improved body armor in combat has led to better survival rates, but proportionally more severe facial injuries are being seen.
What are the immediate priorities when someone has severe facial trauma?
Emergent management absolutely prioritizes the ABCs: airway, breathing, circulation. Airway compromise is a true surgical emergency, often occurring with combined jaw fractures with bleeding and swelling. Securing the airway might involve intubation, or sometimes a cricothyroidotomy or tracheostomy if intubation fails. Life-threatening hemorrhage needs immediate control, usually with direct pressure, packing, or sometimes fracture reduction itself can help stop bleeding from bone edges. Angiographic embolization might be needed for persistent bleeding. And critical vision-threatening injuries must be recognized and treated promptly. Things like increased pressure inside the eye socket, a ruptured globe, or optic nerve compression require urgent ophthalmology consultation and often immediate intervention like a lateral canthotomy to relieve pressure or surgical decompression.
How are these injuries evaluated once the patient is stable?
Evaluation and diagnosis primarily rely on a thorough physical examination looking for deformity, checking nerve function, assessing vision and eye movements, checking dental occlusion, and CT scans. Fine-cut CT with multiplanar reconstruction is really the definitive diagnostic tool now.
What about soft tissue injuries to the face?
The face has an incredibly rich blood supply. This means that even tissue that looks questionable might survive, so surgeons tend to salvage as much as possible. This robust perfusion also helps resist infection, allowing primary repair of lacerations even up to 24 hours after the injury, provided the wound is thoroughly cleaned. Identifying injuries to the facial nerve or the parotid duct, salivary duct, acutely is crucial for successful repair and preventing later complications like facial weakness or salivary fistulas. For craniofacial fractures, the treatment relies on precise craniofacial surgical techniques. Wide surgical exposure to see the fractures clearly, meticulous anatomic reduction, putting the pieces back exactly where they belong, and rigid internal fixation, usually with low-profile titanium miniplates and screws. Bone grafting might be needed if bone is missing or severely crushed.
Why is that precise bony reconstruction so critical?
Failure to perfectly reconstruct the underlying bony skeleton inevitably leads to shrinkage and tightening of the overlying facial soft tissues. And that soft tissue contracture is incredibly difficult, sometimes almost impossible to correct secondarily. So getting the bones right initially is paramount. This applies to fractures of the forehead, the upper midface, zygoma, orbit, nose, the lower midface, maxilla, and the mandible. Restoring proper dental occlusion is a primary goal for maxillary and mandibular fractures.
Is it different in children?
The principles are the same, but there are differences. Children heal much faster, so fractures often need treatment within a week. Fixation is complicated by the presence of developing permanent teeth, which can be easily damaged by screws or plates. Resorbable hardware, which dissolves over time, is frequently used for children now. Moving up, let's talk about scalp reconstruction. Small defects can often be closed primarily. Larger defects might need local scalp flaps, which are elevated, preserving major blood vessels. Incising the inelastic ilia layer can help extend the flap's reach. Tissue expansion is also a great option for reconstructing larger hair-bearing defects. For very large or complex defects, especially those involving irradiated tissue or exposed hardware, distant pedicled flaps or free microvascular tissue transfer, like the free latissimus dorsi muscle flap, are often necessary. Traumatic scalp avulsions can sometimes even be replanted microsurgically with good results. Now for facial reconstruction after tumor resection or trauma, simple skin grafts have limited use on the face due to imperfect tissue match. Full thickness skin grafts from areas like behind the ear offer a better color match. But ideally, local flaps provide the most appropriate thickness, color, and texture. For nasal defects, smaller ones might be closed with local nasal flaps. Larger defects, especially of the tip or ala, often require a staged forehead flap based on the supratrochlear vessels. Complex nasal defects might also need cartilage grafts for support and lining reconstruction. Eyelid reconstruction is highly specialized. Full-thickness skin grafts work well for skin loss. Small full-thickness defects can be closed directly. Larger defects might require mobilizing tissue from the other eyelid or using composite grafts, cartilage and mucosa for support, covered by a local skin flap. Cheek defects can often be managed with local flaps or larger cervicofacial rotation flaps that bring neck and side of face skin centrally. Lip reconstruction is critical for both appearance and function, maintaining oral competence. Precise alignment of the vermilion border, the red part of the lip, and repair of the orbicularis oris muscle are key. Smaller defects close directly. Larger ones require mobilizing surrounding tissue, sometimes using flaps from the other lip, like an Abbey flap or nearby cheek tissue.
This all naturally leads to one of the most groundbreaking and frankly ethically complex areas in plastic surgery today: facial transplantation.
Yes. The first successful face transplantation was performed back in November 2005 in France. Since then, over 40 successful facial composite tissue transplantations involving variable amounts of skin, muscle, nerve, bone, and specific structures like eyelids, noses, and lips have been reported worldwide. All were performed for truly devastating defects not reconstructable by conventional means.
What have the outcomes been like for these patients?
As of late 2018, almost all recipients had experienced at least one episode of acute graft rejection, usually within the first year, which is typically manageable with adjusting immunosuppression. There has been at least one case requiring a second transplant due to chronic rejection. Functionally, recovery has generally been satisfactory. Sensory function tends to recover within about 3 to 8 months, and acceptable motor recovery movement is usually seen between 9 and 12 months, often with ongoing improvement beyond that. Psychologically, the outcomes have been largely positive, greatly attributed to the dedicated psychosocial support these patients receive. Aesthetic outcomes have varied, but are often significantly better than what conventional reconstruction could offer. The core benefit of facial transplantation is providing a potentially better functional and aesthetic outcome for severely disfigured individuals, thereby significantly improving their quality of life. The immediate surgical risks are broadly similar to other major conventional reconstructive procedures. The critical difference and the major long-term risk is the absolute necessity for lifelong multi-drug immunosuppression to prevent rejection of the transplanted tissue and the potential medical risks associated with that immunosuppression itself, as well as the rejection process.
Shifting gears a bit, beyond reconstruction for trauma or congenital issues, plastic surgery also deeply impacts self-image and confidence through aesthetic procedures. This is often what people first think of when they hear plastic surgery.
Absolutely. And facial aesthetic surgery always begins with a very detailed interview, medical history, and clinical examination to identify appropriate candidates. It's absolutely crucial to understand the patient's specific wishes and, importantly, ensure they have realistic expectations about what surgery can achieve. Factors like prior cosmetic surgery, substance abuse, certain medications, or underlying mental or physical health problems can definitely complicate outcomes and need careful consideration. One common procedure is a brow lift. What happens is lateral eyebrow ptosis, or drooping, particularly at the outer edge, is often an early sign of aging. It can give a tired, stern, or even angry appearance. A brow lift aims to address this, often in conjunction with forehead wrinkles and hooding of the upper eyelid skin, especially out towards the temples and maybe crow's feet as well. Essentially, the eyebrow descends below its more youthful position, which is typically at or slightly above the superior orbital rim.
How is that done?
Well, techniques have evolved. The endoscopic technique uses small incisions hidden in the hairline, allowing for extensive dissection underneath to correct the muscles that cause frown lines, like the procerus and corrugator muscles, and freeing attachments around the nose and eye sockets. The older open technique used a long bicoronal incision across the scalp for similar corrections, but is obviously more invasive. Brow ptosis can also sometimes be addressed through blepharoplasty incisions or even direct incisions hidden in the brow hairs. Traditionally, endoscopic and open techniques were standard, but their popularity has decreased somewhat due to concerns about scarring and potential hair loss. More recently, less invasive procedures like targeted botulinum toxin injections and dermal fillers have shown high patient satisfaction and comparable results for certain types of brow aging. Next, blepharoplasty or eyelid surgery. This is one of the most common aesthetic procedures performed globally. In the US alone, there were 150,000 performed back in 2012, just as an example.
Why is it so popular?
It's often sought to treat dermatocallusis, that's excess, creepy skin, as well as bagginess or puffiness, and generally restore a more youthful contour around the eyes and the upper cheek or malar region. It's predominantly performed in females, about 85% of cases, and it's actually the most frequent aesthetic surgery for people aged 51 to 64. But it's considered one of the most challenging procedures to truly master, especially the lower eyelid, due to the delicate anatomy and potential complications. Approaches differ for the upper and lower lids. Upper blepharoplasty addresses excess skin, sometimes eyelid ptosis, drooping of the lid itself, not just the brow, and hollowness or deflation in the upper sulcus. It's typically done through an incision hidden in the natural eyelid crease. Careful marking beforehand is crucial to prevent over-resection of skin, which could lead to legophthalmos, the inability to fully close the eye. Sometimes a small strip of the orbicularis oculi muscle is removed, and protruding pockets of postseptal fat can be carefully resected or repositioned. Lower eyelid blepharoplasty aims to correct orbitomolar deformities, the transition from the lower lid to the cheek. This might involve elevating skin or skin muscle flaps to remove excess skin, muscle, and protruding fat pads. A transconjunctival approach, making the incision inside the lower eyelid, is often used just for fat removal or repositioning, or tightening the orbital septum, especially when minimal or no skin reception is needed. If the lower eyelid itself is lax, which is common with aging, a lateral canthopexy, tightening the outer corner tendon, or a more involved lateral canthoplasty might be performed concurrently to provide better support and prevent the lid from pulling down.
What are the common complications surgeons and patients need to be aware of?
Dry eye syndrome is a potential issue, as is scleral show, where too much white shows below the iris, and ectropium, an aversion or pulling down of the lower eyelid exposing the conjunctiva. Ectropion might require further surgery if it persists. Importantly, the recent trend in surgical technique emphasizes volume preservation. Instead of aggressively removing tissue, surgeons often use fat injections to fill hollows and perform minimal fat removal, along with highly selective muscle adjustments. Preoperative evaluation must include assessing comorbidities, smoking status, and importantly, an ophthalmologic consultation to assess for pre-existing dry eye or prior corneal surgery, which can increase risks. Then there's rhinoplasty, nose surgery, often seen as one of the most complex aesthetic surgeries out there. What makes it so challenging? It is indeed considered very challenging. It refers broadly to surgery of the nose for both aesthetic and functional improvement. The goal is always consistent, reliable, long-lasting, and natural appearing results. The preoperative evaluation has to be incredibly comprehensive, looking at aesthetic concerns, functional issues like breathing problems, and even psychological aspects to ensure realistic expectations. Functional alterations, like a deviated septum causing airway obstruction, can often be objectively measured with imaging. Aesthetically, the nose is incredibly complex. Evaluation requires looking from multiple views: frontal, lateral, basal from underneath, and internally. Surgeons consider specific measurements, how the nose relates to the overall facial context, its length, width, harmony with other features, and even ethnic variations which influence ideal aesthetics. Assessing the nasal bones, the pyramid shape, the dorsal profile, the bridge, the septum, and its relation to the upper lip and chin are all critical. Things like the position of the nasal tip, how much it moves when smiling due to muscle activity, and any asymmetries in the columella, the strip between the nostrils, are key discussion points preoperatively. The difficulty really stems from it being a composite of many different potential procedures performed on numerous delicate anatomic structures, bone, cartilage, skin. This makes each patient's surgical plan highly specific and individualized. Two main approaches exist. Open rhinoplasty, which uses a small incision across the columella, allowing the skin to be lifted for complete exposure and direct vision of the underlying structures. This gives maximal control but leaves a small, usually inconspicuous scar. The closed rhinoplasty, or endonasal approach, uses incisions made entirely inside the nostrils, avoiding any visible external scar, but it doesn't provide the same degree of direct visualization during the surgery. Surgical management might involve resecting a dorsal hump and smoothing the bridge. Osteotomies, controlled fractures of the nasal bones, may be used to close an open roof deformity after hump removal, narrow the bony width of the nose, or straighten the deviated nasal pyramid after septal correction. Refining the nasal tip and improving its projection are often achieved by trimming the upper edges of the alar cartilages, cephalic trim, and using various suturing techniques to reshape and support the tip cartilages, like transdermal or interdermal sutures.
And complications. What can go wrong with rhinoplasty?
Patient dissatisfaction is a notable potential outcome given the subjective nature of aesthetics. Iatrogenic deformities, problems caused by the surgery itself, can occur. Airway obstruction can sometimes worsen or develop. Other risks include hypertrophic scarring, fibrosis, inclusion cysts, granulomas, infection, or extrusion of any implanted materials like grafts. Bleeding occurs postoperatively in about 3 to 4% of patients. Perhaps the greater challenge is the reported 5% to 10% of patients who ultimately require revision or secondary surgery for either aesthetic or functional reasons. Dermal fillers and fat grafting can sometimes be used cautiously as adjuncts, either preoperatively for planning or postoperatively to camouflage minor deformities. Moving on to the classic facelift, technically known as rhytidectomy, what specific signs of aging does it target? Rhytidectomy, literally from the Greek rhytis for wrinkle, aims to correct facial aging by removing and repositioning lax, redundant facial and neck tissues. It was the 6th most popular cosmetic surgery back in 2017, as an example. Facial aging is characterized by several typical changes: mid-face flattening below the eyes, more prominent nasolabial folds, smile lines, deepening of the labiomental crease below the lower lip, downturned mouth commissures creating marionette lines, jowl formation along the jawline, vertical banding of the platysma muscles in the neck, and general neck skin laxity. Again, a thorough history and clinical exam are crucial to identify candidates and prevent complications. Several techniques exist, and they've evolved significantly over time. The early subcutaneous facelift primarily involved dissecting just the skin, redraping it upwards and backwards, and excising the excess. Pioneering work by surgeons like Skoog, Mitz, and Peyronie identified and highlighted the importance of the superficial musculoponeurotic system, SMAS, a deeper layer of fibrous tissue and muscle for achieving more significant and longer-lasting correction of deeper facial tissues, not just the skin. The SMAS can be manipulated in various ways: resected, plicated, folded, and sutured, or repositioned to achieve different results. Some more extensive combined techniques involve undermining even deeper, down to the periosteum covering the bone.
Are there other procedures, often done alongside a facelift, to enhance the results?
Yes, absolutely. Ancillary procedures are very common. Submental lipectomy removes excess subcutaneous fat under the chin to improve the neck contour. Plication of the platysma corrects those vertical neck bands by suturing the edges of the platysma muscles together in the midline. And fat injection or grafting can be used to restore lost volume in areas affected by subcutaneous fat atrophy, such as the temples or cheeks, often performed before the final skin closure. Hematoma, a collection of blood under the skin, is the most common complication after a facelift. Others include unfavorable scarring, alopecia, hair loss around incisions, skin slough, tissue necrosis due to compromised blood supply, and nerve injury. The greater auricular nerve, which provides sensation to the lower part of the earlobe and surrounding skin, is the most commonly injured sensory nerve during a facelift, occurring in perhaps 3% to 5% of cases, usually causing temporary numbness. Injury to branches of the facial nerve, which control facial muscles, is much rarer but more serious. Next, let's discuss hair transplant. Beyond facial features, hair loss is a significant concern for many. How has hair transplantation evolved? Hair transplantation offers a permanent improvement for stable, medically controlled alopecia hair loss. Older, more invasive procedures like scalp reductions or rotating large hair-bearing flaps are much less common now. Hair restoration has evolved significantly towards achieving much better cosmetic and more durable results, with follicular unit transplantation, FUT, and follicular unit extraction, FUE, becoming the mainstays. Modern techniques typically use small punch biopsies around 0.8 1.2 millimeters in diameter to harvest individual follicular units' natural groupings of 1 to 4 hairs. FUE involves extracting these units one by one directly from the donor area, while FUT involves removing a strip of scalp from which the units are then dissected under magnification. Computerized and robotic harvesting systems can now yield a high number of grafts per hour with potentially minimal scarring. After harvest, maintaining the metabolic needs, ionic balance, and osmotic balance of the grafts is crucial to reduce cell death before they're implanted. Bioenhancement solutions containing growth factors or special media can help maintain cell viability during that early grafting phase when nutrients are obtained solely by diffusion. The procedure is typically performed on an outpatient basis, usually with mild sedation and local anesthesia. Multiple sessions may be performed over time. It can take 5 to 8 hours just to transplant 800 to 1,000 follicular units, while a mega session might transplant 3,000 to 6,000 units in a single day. Special attention is devoted to the angle and orientation of the transplanted follicular unit in the recipient site to mimic natural hair growth patterns. After transplant, patients may continue to lose their native hair, and various medical treatments, including bioenhancements, platelet-rich plasma, PRP, and low-level laser therapy, may be used to try and stimulate existing hair growth. Important research is ongoing using growth factors, stem cells, and genetic signaling pathways to better understand cellular control and hair growth regulation. We're also seeing a rapid growth in non-surgical modalities. These continue to increase in popularity every single year as patients seek effective results with less invasiveness and downtime.
Right, the so-called lunchtime procedures.
Exactly. Skin resurfacing treatments aim to improve skin texture, tone, and color. Chemical peeling uses specific agents like glycolic acid, TCA, or phenol for superficial, medium, or deep exfoliation, commonly used for sun damage, melasma, acne, and rosacea. Other procedures include microneedling and dermabrasion, but the most rapidly growing technique here is laser technology. Introduced way back in the 1960s, the early ablative lasers, like CO2 and erbium.YAG, were highly effective. They worked by vaporizing the epidermis and upper dermis and causing thermal coagulation deeper down, leading to robust collagen remodeling and skin tightening. However, they carried significant risks: potential scarring, prolonged redness and swelling, permanent pigmentation changes, and an increased risk of infection due to the complete removal of the skin barrier.
That sounds pretty intense.
It was. This led to the revolution of fractional photothermolysis around 2003. This newer class of therapy delivers dermal coagulative injury without causing confluent epidermal damage. It creates microscopic columns of thermal injury surrounded by islands of undisturbed normal skin. These untreated areas act as reservoirs for rapid healing, allowing complete reepithelialization within just 24 to 48 hours, while still stimulating significant connective tissue synthesis and skin tightening over time. The results can be comparable to full-surface ablative lasers, but with far fewer side effects and much less downtime. Indications include facial wrinkles, sun-damaged skin, and acne scarring. Benefits include softening wrinkles, improving texture and tone, decreasing pore size, and reducing skin laxity. The entire face, neck, and chest can be treated. For scars, fractional lasers can flatten hypertrophic scars and stimulate collagen production beneath atrophic scars, smoothing the skin topography, usually requiring a series of treatments. Then we have injectables, specifically dermal fillers.
These have become incredibly popular. What are they typically used for, and what are the main types available?
Yes, there's been a huge increase in the use of dermal fillers to improve facial appearance and achieve rejuvenation, primarily by correcting wrinkles and restoring lost volume. Common areas treated include the glabellar lines between the brows, horizontal forehead lines, and lateral brow lines in the upper face. In the mid and lower face, popular areas are the tear troughs, nasogenital folds, nasolabial folds, cheeks, chin, and imperial wrinkles around the mouth. Fillers can be broadly categorized as autologous, derived from the patient's own body, or non-autologous, and also classified by their duration as non-permanent, semi-permanent, or permanent. Autologous fat transfer, using the patient's own harvested fat, has shown promise for rejuvenation, improving skin appearance, reducing wrinkles and pore size, and even improving pigmentation. Fat is also used therapeutically to improve scars, depressions, asymmetries, radiation damage, chronic ulcers, and burn scars. However, as we discussed regarding breast surgery, leading plastic surgery societies have stated that autologous fat transfer to the breast may potentially compromise breast cancer detection and should be administered cautiously in high-risk patients, while strongly supporting ongoing research into its safety and efficacy. Its role in cosmetic and reconstructive breast surgery is still evolving, currently used sometimes for lumpectomy correction, augmentation enhancement, and asymmetry correction. A significant challenge remains the lack of standardization in harvest and surgical technique, which can lead to patient dissatisfaction and reoperations due to unpredictable fat reabsorption, questioning the procedure's long-term durability. More research is definitely needed here, including understanding the role of adipose-derived stem cells. Non-autologous materials, often derived from organic sources like hyaluronic acid or collagen or synthetic sources, offer off-the-shelf availability and ease of use. However, some older biologic materials carried risks of sensitization or immunogenicity. The search continues for better tolerated, longer-lasting new materials. The two major types of biologic tissue fillers currently used are collagen products, less common now, and, much more predominantly, hyaluronic acid HA products. Synthetic materials can offer permanence, but many older permanent fillers have been largely abandoned due to high rates of complications like granulomas.
What about complications with these injectables? They seem relatively straightforward, but are there risks?
Adverse effects can occur early, late, or delayed. Early complications right after injection include bruising, swelling, edema, redness, erythema, and rarely but seriously, tissue necrosis due to vascular compression or direct injection into a blood vessel occlusion. Late and delayed adverse effects, appearing anywhere from 14 days to over a year later, can include nodules, granulomas, inflammatory lumps, chronic infections, and inflammatory reactions, sometimes related to biofilm formation, which may ultimately require surgical removal. Several actions are recommended to avoid and manage severe complications: using blunt-tipped cannulas instead of sharp needles where possible, using low injection pressure, injecting small amounts boluses at a time, aspirating before injecting, though the value of this is debated, having detailed anatomical awareness of vessel locations, and sometimes using local anesthesia containing epinephrine, which causes vasoconstriction, potentially reducing arterial lumen size and bleeding. In cases of suspected vascular occlusion with HA fillers, injecting hyaluronidase, an enzyme that dissolves HA, immediately may help restore blood flow. A very rare but devastating complication that has been described is central retinal artery embolism from filler injected near the eye, resulting in blindness. So, while generally safe in experienced hands, these are medical procedures with potential risks.
Okay, shifting from the face, let's move to breast surgery. This is an area where plastic surgeons address both very significant physical concerns, like pain from overly large breasts, and profound psychological concerns related to body image and identity.
Absolutely, it's a huge part of the specialty. We can start with reduction mammoplasty or breast reduction. Breast hypertrophy is essentially excessive breast development without any underlying pathology. Reduction mammoplasty surgically resects excess fat, glandular breast tissue, and skin to achieve a more proportional breast size. The guiding principles are always to improve the patient's symptoms, like back, neck, and shoulder pain, skin irritation, decrease the breast volume, reshape and elevate the breast to a more anatomically correct and youthful position, appropriately reposition the nipple and areola complex, preserve nerve and blood supply as much as possible for sensation and viability, and minimize scarring. It addresses both physical symptoms and often significant psychological distress. Over 100,000 breast reductions were performed in the U.S. back in 2014 as an example, and it consistently has an extremely high patient satisfaction rate, often quoted around 97.5%. Surgical techniques are typically described by where the nipple and areola remain attached to maintain their blood supply. This is called the pedicle, and by the resulting incision pattern. The most common incision pattern is the Wise pattern, or anchor scar, often used with an inferiorly based pedicle technique, which accounts for about 80% of cases. Other pedicle options include central, superior, medial, lateral, or even doubly attached pedicles. Vertical scar techniques, often based on superior or medial pedicles, have gained interest as they avoid the horizontal inframammary scar. In cases of very large breasts, gigantomastia, the distance the nipple needs to travel might be too long for a standard pedicle, increasing the risk of ischemia. In these situations, amputation-style techniques with a free nipple graft, where the nipple is completely removed and reattached as a graft, might be used. Suction-assisted lipectomy, liposuction alone, can sometimes be sufficient to reduce volume for patients with mild to moderate hypertrophy, primarily fatty breasts, good skin tone, and minimal ptosis, drooping.
What are the key pre-op considerations, and what are the most common complications patients should be aware of?
Preoperative breast cancer screening with a mammogram is usually performed for patients 35 or older or those with risk factors. Most procedures are performed on an outpatient basis now, about 85%. General anesthesia is common. Stopping oral contraceptives about a month prior is often recommended due to a potential increased risk of venous thrombosis, blood clots. Early ambulation after surgery and graduated compression stockings are mandatory preventative measures. High-risk patients might receive perioperative chemoprophylaxis, blood thinners, to further reduce VTE risk, though this must be weighed against the increased risk of bleeding or hematomas, which occur in up to 5% of cases. Using epinephrine in the local anesthetic helps reduce blood loss during surgery. Interestingly, the routine use of surgical drains hasn't shown a significant difference in hematoma rates. The most frequent complications include altered nipple areola sensibility, numbness or hypersensitivity, often temporary, hematoma, seroma, fluid collection, wound dehiscence, opening of the incision, and fat or skin necrosis, tissue death due to compromised blood supply, particularly at the T-junction of the anchor scar. Related to reduction is mastopexy, commonly known as a breast lift. This procedure corrects breast paestosis, which is the downward displacement of the breast glandular tissue and nipple areola complex. It's caused by factors like skin laxity, poor elasticity, or impaired fascial and suspensory ligaments, Cooper's ligaments. Contributing factors include pregnancy, lactation, postmenopausal involution, significant weight loss, and simple aging. Ptosis is often classified based on the position of the nipple areola complex relative to the inframammary fold, the crease under the breast, and the bulk of the breast mound, with a Regnault classification being widely used. Grade 1, nipple at fold. Grade 2, nipple below fold. Grade 3, nipple and most breast tissue below fold. Options for correction include mastopexy using techniques similar to breast reduction, reshaping the tissue and removing excess skin, or sometimes combining a lift with breast augmentation to restore lost volume. The markings and surgical techniques often resemble those used for breast reduction. The main challenge is balancing the tightening of the skin envelope with restoring or maintaining adequate breast volume. It's also important for patients to understand that the effects of a lift alone are often temporary, and some degree of ptosis will inevitably recur over time due to gravity and tissue changes. Next, breast augmentation. This remains the most popular cosmetic surgical procedure performed worldwide, consistently showing high patient satisfaction rates. It's typically done for women dissatisfied with naturally small breasts or those who have lost breast volume after pregnancy, weight loss, or aging. Silicone gel implants were first developed back in 1963. Regulatory bodies like the FDA have approved numerous devices over the years, including newer generations of both saline-filled and highly cohesive form-stable silicone gel implants. These newer gummy bear gel implants have a thicker, more viscous, cohesive gel that tends to stay in place even if the outer shell ruptures. Saline-filled implants consist of a silicone rubber shell that's filled with sterile saline solution in the operating room after insertion.
What are the pros and cons of saline versus silicone?
Saline implants' advantages include the benign nature of saline if leakage occurs, the flexibility for the surgeon to adjust the size during surgery, and the ability to use smaller incisions since they're inserted empty. Disadvantages include a potentially higher incidence of palpable or visible rippling or wrinkling, especially in thin patients, and a higher rate of deflation over time. Comprehensive patient education on all potential complications, both early and late, is absolutely paramount before augmentation surgery. Perioperative complications are relatively low. Bleeding or hematoma occurs in perhaps 1–3% of cases, wound infections in 1–2%, and diminished nipple areola sensibility is reported in around 15% of patients, though this depends somewhat on the incision type and implant position. More numerous and sometimes more serious sequelae can present weeks or even years later. Implant-related complications are the main concern long-term. Capsular contracture, the formation of tight, sometimes painful scar tissue around the implant, occurs in roughly 15% of patients at 3 years, rising to 11–19% at 8–10 years post-op. Implant deflation happens in about 7% of saline implants within 5 years, usually due to valve issues, damage during handling, pressure, trauma, or sometimes for unknown reasons. Implant rupture can occur with silicone gel implants. If the gel is highly cohesive, it may not leak out significantly, leading to a silent rupture only detectable on imaging. Current recommendations often suggest MRI screening for silicone gel implant rupture starting at 3 years post-op and then every 2 years thereafter, although compliance with this is variable. In the U.S., about 90% of patients currently receive smooth-surfaced implants, and around 60% are silicone-filled. Smooth implants are known to be more prone to capsular contracture, particularly when placed in the subglandular above the muscle plane. Whether shape anatomic implants provide consistently superior aesthetic results compared to round implants remains somewhat debated, and rotation of an anatomic implant can be a complication requiring additional surgery. Implant profile, how much it projects forward, is selected based on the patient's chest width and desired outcome. Incision options vary. The inframammary technique, in the fold under the breast, is most common, providing excellent access, though the scar may be noticeable in some positions. Surgeons often use nipple shields, glove changes, and insertion funnels, the no-touch technique, as strategies to minimize bacterial contamination during insertion, which is thought to decrease capsular contracture rates. Periolar incisions around the nipple can heal with less visible scarring, but may have a slightly higher risk of altered sensation and potentially capsular contracture due to proximity to nipple ducts. Axillary incisions in the armpit leave no visible scar on the breast itself and are often ideal for saline implant insertion. Implant placement can be subglandular, directly under the breast tissue, subfascial, under the fascia covering the pectoralis muscle, or submuscular, partially or fully under the pectoralis major muscle. Submuscular placement generally offers better coverage of the upper part of the implant, upper pole aesthetics, allows for better mammography visualization, and is associated with a lower rate of capsular contracture. However, it typically involves more postoperative discomfort, a longer recovery period, and potential breast distortion or animation deformity with pectoralis muscle contraction. Hematoma and infection occur in less than 1% of primary augmentations. Impaired nipple areola sensibility is more frequent with larger implants and more aggressive pocket dissection. Secondary or revision surgery rates range widely, from under 1% to as high as 36% reported over a 10-year period, commonly due to implant failure, rupture deflation, malposition, or capsular contracture. Let's touch on fat grafting to the breast again briefly. As mentioned, autologous fat injection is popular in both cosmetic and reconstructive settings. First used for soft tissue deformities and facial rejuvenation in the mid-90s, its use in breast augmentation, enhancement combined with mastopexy, and correction of breast asymmetry has gained popularity. However, concerns remain, particularly regarding potential interference with breast cancer detection. Leading plastic surgery societies advise caution in high-risk patients and strongly support ongoing research into its safety and efficacy in the breast. The lack of standardization in harvest, processing, and injection techniques is a major issue, often leading to patient dissatisfaction due to unpredictable and often significant fat reabsorption, especially early on. This questions the procedure's long-term durability and predictability compared to implants. Common reported complications include fat necrosis, firm lumps of dead fat cells, oil cysts, and potentially capsular contracture if used around implants. Many questions remain about optimizing techniques, and more studies are needed, especially regarding the role and behavior of adipose-derived stem cells within the grafted fat.
This raises another important safety question. What exactly is BIA-ALCL, breast implant-associated anaplastic large cell lymphoma? Why is it such a significant concern now?
BIA-ALCL is a rare but recognized type of T-cell lymphoma that has been clearly associated with breast implants. Several factors seem to be involved in its development, including the presence of textured surface implants rather than smooth, chronic inflammation potentially triggered by bacterial biofilm formation on the implant surface, an underlying immune response, and possibly patient genetic susceptibility. The first case was documented in 1997, and importantly, no cases have been reported from the era before textured implants were widely used. About half of the reported cases occurred in patients who had implants for breast reconstruction after mastectomy. While its exact incidence is still debated and appears low overall, the prevalence seems to be increasing as both patients and practitioners become more aware of the condition. The mean age at onset is typically in the 5th decade, with implants usually having been in place for at least 10 years. The most common clinical presentation is a late peri-implant effusion, or seroma, a fluid collection around the implant appearing more than 1 year after the initial implantation surgery. Less commonly, it can present as a mass or capsular contracture. Axillary lymph node involvement was reported in about 10–14% of cases initially. Patients with textured implants have a significantly higher rate of diagnosis compared to those with smooth implants. More recently, certain types of textured implants were removed from the market in various regions due to this association.
How is BIA-ALCL diagnosed and treated?
Ultrasound is typically the first imaging choice if a patient presents with breast swelling or a suspected late seroma, and it can guide fine needle aspiration of the fluid. MRI is also used. Cytologic analysis of the aspirated paraprosthetic fluid is key. It will show characteristic large pleomorphic lymphocytes. Immunohistochemistry confirms the diagnosis, as BIA-ALCL cells are reliably CD30 positive and usually ALK negative. Confirmed cases must be reported to national registries and regulatory bodies like the FDA. Once diagnosed, staging is done, usually with a PTT scan. The standard surgical treatment involves complete removal of the implant, complete surgical removal, capsulectomy of the surrounding scar capsule, and excision of any associated mass with clear margins. There doesn't appear to be a role for sentinel lymph node biopsy. Some patients, particularly those with more advanced disease that has spread beyond the capsule, may receive chemotherapy and other adjuvant therapies, typically under the guidance of a medical oncologist. Finally, for breast surgery, let's cover gynecomastia, or male breast enlargement. This is actually a very common deformity affecting adolescent and adult males. Its etiology is multifactorial, but most frequently it's idiopathic, meaning no specific underlying cause is found. Prevalence estimates range widely, from 38% up to 64% in younger patients, occurring bilaterally in about half of cases. The exact pathophysiologic mechanism isn't fully understood, but an imbalance between estrogen, estradiol, and androgen testosterone levels or activity is thought to be involved. In adolescence, it often resolves spontaneously without intervention. Pathologic gynecomastia, however, can be associated with underlying medical conditions like cirrhosis, malnutrition, renal disease, hypogonadism, or thyroid diseases. It can also be linked to certain tumors, testicular, adrenal, pituitary, or lung, drug abuse, G marijuana, anabolic steroids, and various prescription pharmacologic agents like spironolactone, cimetidine, ketoconazole can also induce gynecomastia. Various classification systems exist, correlating the degree of breast enlargement, the type of tissue, glandular versus fatty, and skin redundancy with appropriate surgical treatment options. Most patients are asymptomatic, though some experience soreness or nipple sensitivity.
When is surgery actually indicated for gynecomastia?
Indications for surgery typically include symptomatic gynecomastia that persists for over 18 to 24 months in adolescence, after allowing time for spontaneous resolution, long-duration gynecomastia in adults that has likely progressed to fibrosis, making it unlikely to resolve, or gynecomastia occurring in patients at higher risk for male breast cancer, for example, those with Klinefelter syndrome. Surgical treatment can involve direct excision of the glandular breast tissue, suction-assisted liposuction to remove fatty tissue, skin resection to address redundancy, or often a combination of these. Liposuction alone may suffice for cases primarily involving fatty tissue accumulation, pseudogynecomastia. An open incisional technique, often using a periolar incision around the lower half of the areola, allows for direct surgical adenectomy, removal of the glandular tissue. For patients with significant skin redundancy and ptosis, an approach involving more extensive skin resection, sometimes similar to female breast reduction patterns with or without nipple areola transposition, can be done. In severe cases of massive gynecomastia, a free nipple graft after block resection of the breast tissue might be necessary. Common complications include hematomas, seromas, infections, contour irregularities, and potential areolar or skin flap ischemia or necrosis.
Okay, moving on to body contouring. This area has really gained prominence, especially with the significant increase in bariatric surgery for weight loss.
What are these procedures aiming to achieve?
Abdominoplasty, commonly known as a tummy tuck, remains a very common aesthetic and reconstructive procedure. Patients typically present with a combination of excess adiposity, fat, skin laxity, loose skin, rectus muscle diastasis, separation of the six-pack abdominal muscles, often after pregnancy or weight gain, and stria, stretch marks. The procedure fundamentally involves removing the excess sagging skin and fat via a lower horizontal skin incision, typically running hip to hip, hidden below the bikini line. Simultaneously, muscle and fascia application, suturing the separated rectus muscles back together in the midline, corrects the diastasis and tightens the abdominal wall. It can often be combined with liposuction to the anterior abdomen, flanks, love handles, and other areas of the trunk to further improve contour. Depending on the amount of tissue excised and the specific deformities present, procedures range from a mini abdominoplasty, addressing only laxity below the umbilicus, to peniculectomy, removing a large overhanging apron of skin and fat, often for functional reasons, and full abdominoplasty, addressing the entire abdomen, usually involving repositioning the umbilicus. In a full abdominoplasty, the anterior abdominal flap, containing skin and subcutaneous tissue, is elevated off the muscle layer, typically from the pubic hairline up to the ribs, xiphoid costal margin. The umbilicus is usually left attached to the underlying muscle on its stalk and then re-exteriorized through a new opening made in the re-draped abdominal flap. Various incision types are used, but the horizontal lower abdominal incision is most frequent. For patients with significant upper abdominal laxity or after massive weight loss, a fleur-de-lis abdominoplasty, which adds a vertical midline incision to the horizontal one, forming an inverted T, allows for greater tissue resection and tightening in both dimensions. A corset abdominoplasty is another variation sometimes used for massive weight loss patients.
What are the key risks and complications associated with abdominoplasty? And how are they managed to ensure patient safety, especially given it's often considered cosmetic?
Pre-existing abdominal scars from previous operations, like C-sections or gallbladder surgery, must be carefully evaluated, as they can potentially compromise blood supply to the abdominal flap, increasing the risk of ischemia and necrosis, skin death. Prophylactic antibiotics are standard practice before incision. Adequate perioperative pain control using multimodal analgesia, combining different types of pain relief, is critical for patient comfort, early mobilization, and preventing complications. Patients with certain comorbidities, like diabetes, or those with a BMI greater than 30 km2, face a higher risk of complications. Minor complications include surgical site infections, seroma, fluid collection under the flap, hematoma, blood collection, and wound dehiscence, incision opening. Progressive tension sutures, which tack the flap down to the underlying fascia, are increasingly used to help reduce the incidence of seroma. Smokers are at significantly higher risk for infectious complications and delayed healing. Major complications, though less common, include necrosis of the abdominal flap, deep venous thrombosis, DVT blood clot in the leg veins, and pulmonary embolus, PE clot traveling to the lungs. These risks are more frequent when abdominoplasty is combined with other major procedures, especially intra-abdominal or gynecologic surgeries. Routine chemoprophylaxis, blood thinners, for VTE prevention is generally not indicated for low-risk patients undergoing abdominoplasty alone, but mechanical prophylaxis like intermittent pneumatic compression devices are standard. Chemoprophylaxis is considered on a case-by-case basis for patients identified as high risk using scoring systems like the Caprini score. A very specialized and growing area within this is body contouring after bariatric surgery. After massive weight loss, often 100 pounds or more, patients are typically left with profound excess skin and subcutaneous tissue that has lost its elasticity and fails to retract. This skin hangs loosely from the torso, abdomen, breasts, arms, and thighs.
That must present unique challenges.
It does. This skin redundancy can be physically burdensome, painful, limit mobility, interfere with clothing fit, and lead to functional problems like chronic impetigo, rashes, and infections in skin folds. These patients often have underlying metabolic alterations from their weight loss journey that require detailed preoperative workup. Assessing patient motivations, specific concerns, and expectations is crucial, as is psychological assessment to screen for unrealistic expectations, body dysmorphic disorders, or unresolved eating disorders. Since higher BMI correlates strongly with surgical complications, patients must typically maintain a stable weight for at least 6 months before undergoing contouring surgery, and surgery is usually planned 12 to 18 months after their bariatric surgery, allowing time for nutritional stabilization. Proper nutritional assessment to identify and correct deficiencies in protein, iron, vitamins like B12, D, and minerals is essential. Smoking is a major risk factor for ischemic complications and delayed wound healing in these procedures. Surgeons usually require at least 4 weeks of complete tobacco abstinence, often confirmed with a negative urine nicotine test before operating. It's also important to screen for and optimize any underlying pulmonary, cardiac, endocrine, or hematologic conditions and rule out abdominal or inguinal hernias which might need concurrent repair. Surgeons must have extensive discussions with patients about the significant trade-off involved, accepting long, permanent scars in exchange for improved body contour and thoroughly explaining the potential complications. Common complications include infections, bleeding, fluid collections, seromahematoma, skin necrosis, especially at incision junctions, wound dehiscence, asymmetric scars, contour irregularities, and venous thromboembolism. These patients often have skin with inherently poor elasticity and tone, which can affect healing and the final result. These surgeries often require multiple stages, sometimes 3 or 4 separate operations spread over a year or 2. Combining too many procedures in one sitting significantly increases complication risks. Typically, surgeons might combine one upper body procedure, like breast lift, arm lift, with a lower circumferential body lift in carefully selected patients with a BMI under 30 kilograms 2 and a good overall medical profile. Station procedures are usually planned every 3 to 6 months. VTE risk reduction is paramount, involving patient education, thorough risk assessment, for example, Caprini score, and preventative measures, including both mechanical compression devices and often chemical blood thinners prophylaxis, especially for longer or combined procedures.
These procedures must have such a profound impact on the overall well-being and life quality of these massive weight loss patients, truly completing their transformation journey.
They absolutely do. They have a tremendous impact. These surgeries help patients not only to maintain their hard-won weight loss by making exercise easier and more comfortable, but also to achieve a body shape that better reflects their new health status. And crucially, they significantly improve psychological wellness, body image, and self-esteem. It's often the final step in their journey. Specific procedures include mini abdominoplasty for limited laxity below the navel, paniculectomy, a functional procedure just removing the overhanging apron, often covered by insurance if medically necessary for hygiene issues, but doesn't typically address muscle diastasis or the umbilicus. Abdominoplasty, traditional and reverse. Reverse abdominoplasty addresses upper abdominal laxity with an incision under the breasts. Vertical abdominoplasty, fleur-de-lis, for significant laxity in both horizontal and vertical dimensions. Upper trunk contouring, reshaping the breasts, mastopexy, possibly with implants or fat grafting, and addressing upper back rolls often requires long horizontal or oblique scars. Bra line back lift, brachioplasty arm lift, and medial thigh lift. Reshape arms and thighs by excising long ellipses of excess skin and fat along the inner aspects. Lower body lift procedures, often a circumferential lift, belt lipectomy, addressing the abdomen, flanks, outer thighs, and buttocks in one procedure with a circumferential incision. And then, of course, there's liposuction, also known as lipoplasty or lip sculpture. This is the surgical removal of localized deposits of subcutaneous fat. Liposuction was introduced in the late 1970s and is now one of the most common cosmetic procedures performed, often combined with many other plastic and reconstructive procedures. A careful history and physical examination are essential, paying special attention to previous scars and checking for hernias that could potentially be injured by the suction cannula. It can be performed on an outpatient basis in various settings, office, surgery center, hospital. Many surgeons prefer general anesthesia, though it can be done under local or regional anesthesia as well. The tumescent technique, developed by Dr. Jeffrey Klein in 1987, really revolutionized the safety and efficacy of liposuction. It involved injecting large volumes of a dilute solution containing lidocaine for local anesthesia, allowing higher total doses up to 35-55 milligrammi, typically cited, and epinephrine for vasoconstriction, reducing bleeding, maximum dose usually 0.07 kilograms, often with sodium bicarbonate added to reduce the stinging of injection. Various cannulas are used, generally blunt-tipped, to minimize the risk of perforation, with smaller diameter cannulas helping to minimize contour irregularities. Suction is typically performed primarily in the deep or intermediate fat layers. Areas where skin has dense fibrous attachments to the underlying deep fascia should generally not be sectioned aggressively to prevent irregularities. Technology has continued to enhance liposuction. Power-assisted liposuction, PAL, uses a vibrating cannula to help break up fat, reducing operator fatigue and potentially increasing speed. laser-assisted liposuction, LAL, radiofrequency-assisted liposuction, RFAL, and ultrasound-assisted liposuction, UAL, use different energy modalities delivered through specialized cannulas. These technologies offer potential benefits like coagulating small blood vessels, reducing bruising, helping rupture adipocytes, fat cells, potentially improving retraction and tightening of the overlying skin by heating the reticular dermis, although robust evidence comparing long-term outcomes between technologies is sometimes limited. Large volume liposuction, generally defined as removing more than 5 liters of total aspirate, is associated with potential risks like hemodynamic instability, significant fluid shifts, and blood loss, requiring careful monitoring and fluid management, often in a hospital setting. However, suction-assisted lipectomy is also a useful surgical treatment for several medical disorders beyond pure aesthetics. As mentioned, it's a treatment of choice for many cases of gynecomastia. It can reduce contour deformities under the arms and laterally after breast reduction. It helps reduce localized fat deposits like the buffalo hump, sometimes seen with certain medical conditions or medications, or fat pads on the upper back and lower neck. For HIV patients with lipodystrophy, a syndrome of abnormal fat distribution, often associated with older protease inhibitor medications, causing fat accumulation in some areas like the neck bag and fat loss in others like the face limbs, liposuction can effectively treat the areas of fat accumulation.
Are there significant risks involved with liposuction, given how common it seems?
With appropriate patient selection, careful technique, and adherence to safety guidelines, especially regarding fluid management and lidocaine dosage, many complications can be avoided. The most common complications are contour irregularities, lumps, bumps, divots, seromas, hematomas, temporary numbness or altered sensation, and potentially skin discoloration. Lidocaine toxicity and fluid overload are risks, particularly with large volume liposuction, if guidelines aren't strictly followed. Lethal complications, though thankfully rare, have been reported and include pulmonary embolisms, fat globules traveling to the lungs, sepsis, severe infection, necrotizing fasciitis, a rapidly spreading soft tissue infection, and perforation of abdominal viscera, bowel injury. The risk of complications definitely increases when liposuction is combined with other major abdominal procedures or when performed with poor standards of sterility or inadequate monitoring.
Our sources briefly mentioned gender affirmation surgery. How does this emerging and important field fit into the broader landscape of plastic surgery?
Gender affirmation surgery is definitely an evolving field, and it's increasingly becoming a significant focus of practice and training within plastic and reconstructive surgery. While the specific techniques themselves are constantly being refined and developed, they are directly benefiting from the immense innovations across the entire specialty that we've discussed today. This includes advancements in microsurgery, essential for procedures like phalloplasty, complex craniofacial surgery techniques used for facial feminization or masculinization, sophisticated body contouring methods for chest masculinization, feminization, hip buttock augmentation, and various aesthetic surgery principles. Numerous specialized techniques and clinical practice guidelines are actively being developed and updated by professional societies. This field is truly at the cusp of establishing itself as its very own distinct subspecialty within plastic surgery, reflecting its growing importance, complexity, and the unique needs of the patient population.
Okay, let's zoom back in now to a fundamental aspect of healing that really underpins so much of what plastic surgeons do. Managing wounds. What defines a wound in this context, and how are they generally categorized?
Broadly speaking, a wound is simply a disruption in the continuity of the epithelial lining the surface layer of the skin or mucosa, like the inside of the mouth. This disruption can be due to all sorts of causative factors: trauma, surgery, pressure, burns, disease processes. Wounds are generally categorized based on their healing duration. We talk about acute wounds, which occur suddenly, maybe from an accident or a planned surgical incision, and typically heal in a predictable time frame. Surgical wounds themselves are further differentiated by their level of contamination, clean, contaminated. Then you have chronic wounds, which represent a failure of the normal healing process. These are wounds that fail to progress through the orderly stages of repair over a prolonged period, typically defined as longer than 4 to 6 weeks, impeding the restoration of normal anatomical structure and function, and that wound healing process itself. It's an incredibly complex, yet beautifully orchestrated, simultaneous cascade of biological events, all working together to restore tissue integrity. It's traditionally divided into 3 overlapping phases. 1. Hemostasis and inflammatory response. This begins immediately after injury. Blood vessels constrict briefly, then dilate. Vasoactive substances like histamine and cytokines are released, increasing local vascular permeability, leading to plasma exudate, swelling. Platelets aggregate to form a clot, stopping bleeding, hemostasis. Neutrophils, a type of white blood cell, are the predominant cells for nonspecific defense in the first 48 hours, cleaning up bacteria and debris. They're then gradually replaced by macrophages around day 4, which are more powerful phagocytes, debris eaters, and also play a crucial role in signaling the next phase. 2. Proliferative phase. This phase typically begins after day 4 and lasts for several weeks. Fibroblasts, the main cells of connective tissue, migrate into the wound and start producing large quantities of collagen, initially disorganized collagen type 3, forming the scaffold for repair. Endothelial cells, which line blood vessels, enter a rapid growth phase, and angiogenesis, the formation of new capillary bloods, occurs. This combination of fibroplasia, fibroblast activity, and revascularization generates a rich vascular network of granulation tissue, that healthy pink red bumpy tissue you see in a healing wound. Myofibroblast cells, specialized fibroblasts with contractile properties, also appear and play a key role in wound contraction, physically pulling the wound edges closer together and reducing its size. Simultaneously, epithelial resurfacing, epithelialization, starts from the wound margins, with skin cells migrating across the granulation tissue bed to cover the defect. 3. Remodeling maturation phase. This is the longest phase and can take anywhere from 15 days up to a year, or even longer in some cases. During this time, the collagen laid down in the proliferative phase becomes more organized. The weaker collagen type 3 is gradually replaced by stronger, more oriented collagen type I. Cross-linking between collagen fibers increases the wound's tensile strength, though it rarely reaches 100% of original tissue strength. The wound becomes less vascular, less red, and less inflamed over time. As the scar redness dissipates, its true final pigmentation appears.
What happens when this intricate multi-stage process breaks down? Why do some wounds just fail to heal, becoming chronic?
That's the crux of chronic wounds. They represent a significant clinical challenge affecting millions of people and consuming vast healthcare resources. These wounds essentially get stuck in one of the phases of healing, usually the inflammatory phase, and fail to progress through the normal tissue repair sequence. This results in that prolonged healing time over 4 to 6 weeks that impedes the restoration of normal structure and function. There are several common types of chronic wounds, each with specific underlying causes. Pressure ulcers, or pressure injuries. These are caused by prolonged, unrelieved pressure, usually over a bony prominence, like the sacrum, heels, hips, which cuts off blood supply and leads to tissue death. They're especially common in the elderly and individuals with impaired mobility or sensation. Venous ulcers. These are the most common type of chronic leg ulcer, accounting for perhaps 80% of them. They're caused by underlying chronic venous insufficiency, incompetent valves in the leg veins, and failure of the calf muscle pump mechanism. This leads to venous hypertension, high pressure in the veins, and leakage of fluid and macromolecules into the surrounding tissues, causing inflammation and breakdown. They tend to be irregular, shallow ulcers, often located on the lower leg, around the ankle, the gaiter area, frequently accompanied by signs of venous disease like varicose veins, dermatitis, and brown hemosiderin staining of the skin. Diabetic foot ulcers. A huge problem affecting millions of people with diabetes worldwide. They are typically multifactorial. The primary driver is often diabetic neuropathy nerve damage, leading to loss of protective sensation in the feet. This means patients don't feel repetitive trauma from ill-fitting shoes or stepping on objects, leading to skin breakdown. Autonomic dysfunction, affecting sweat production and skin dryness, and peripheral vascular insufficiency, poor blood flow, often contribute significantly. High pressure points on the sole of the foot are particularly at risk. Peripheral artery disease dramatically increases the risk of non-healing and infection, with about 20% of moderate to severe diabetic foot infections ultimately leading to amputation. Ischemic arterial ulcers. These are caused by inadequate arterial blood supply, perfusion, due to atherosclerosis, hardening of the arteries, affecting medium or large arteries in the legs. Patients often complain of pain, especially at rest or when the leg is elevated, claudication or rest pain. Smoking, diabetes, hypertension, and high cholesterol are major risk factors. These ulcers are often well demarcated, sometimes described as punched out, and frequently located over pressure points, toes, the lateral foot, or malleolae, ankle bones. The wound base typically looks pale, gray, or yellow, with poor granulation tissue, often surrounded by necrotic tissue or ischemic borders. Radiation wounds. Radiation therapy, while crucial for cancer treatment, has both acute and chronic damaging effects on skin and underlying tissues. It impairs the wound healing cascade by altering the function of fibroblasts, keratinocytes, and endothelial cells, and decreasing the availability of essential mediators, growth factors, and cytokines. DNA damage from radiation also alters normal cell replication, hindering repair. These wounds can develop months or even years after radiation exposure, infected wounds. While bacterial contamination is common in most chronic open wounds, active infection causes local and systemic effects that significantly impair wound healing. Diagnosis is primarily clinical, looking for signs like increased redness, warmth, tenderness, swelling, purulent discharge cellulitis. Quantitative wound culture showing high bacterial counts, 105 organisms per gram of tissue, can confirm infection. Removing non-viable and necrotic tissue, debridement, is essential, as it harbors bacteria. Uncontrolled localized infection can progress to spreading cellulitis, lymphangitis, infection tracking up lymphatic vessels, bacteremia, bacteria in the bloodstream, and systemic sepsis. Importantly, biofilms, organized communities of bacteria encased in a protective matrix, often form in chronic wounds. These biofilms protect bacteria from the host immune system and antimicrobial agents, and they induce a state of chronic, non-resolving inflammation that perpetuates the non-healing state.
Given this complexity and the different underlying causes, how do medical professionals meticulously assess these chronic wounds to figure out the best course of action and tailor treatment plans effectively?
Assessment always begins by classifying the wound. Is it acute or chronic? For any patient presenting with a wound, a complete and detailed clinical history and physical examination are absolutely necessary. This includes medical history, vascular disease, social history, and surgical history to identify any factors that might be impairing healing. Crucial wound-specific history includes its onset, suspected causative factors, how it has changed over time, previous treatments received, associated symptoms like pain or odor, the amount and type of exudate drainage, and any associated neuropathy, loss of sensation. Visual inspection identifies key attributes: the number of wounds, their exact location, size, measuring length, width, and depth consistently, the characteristics of the ulcer itself, shape, edges, base, the appearance of the wound borders, and the condition of the peripheral tissues surrounding the wound. Using photography can help track progress and reduce variability between observers. The characteristics of the wound edge, or example, the wound electrical shapes, often provide clues to the underlying etiology. Probing the wound gently with a sterile instrument helps determine its depth and identify any sinus tracts or undermining, tunnels extending under the skin edge. Signs of infection, as mentioned, include increased warmth, tenderness, pain, and purulent secretions. Any necrotic tissue, eschar or slough, requires debridement. The quantity and quality of exudate help guide the choice of dressings. Vascular assessment is absolutely vital, especially for lower extremity wounds, to determine signs of arterial occlusion or peripheral arterial disease. This includes checking for peripheral pulses, assessing capillary refill time, looking for signs like skin atrophy, lack of hair growth, and deformed nails. Simple diagnostic tests include measuring the ankle brachial index, ABI comparing blood pressure in the ankle to the arm, and ABI 0.9 suggests significant arterial disease. Duplex ultrasound provides more detailed information about blood flow, and plethysmography measures volume changes. Referral to a vascular surgeon or interventional radiologist for angiography and potential revascularization, like angioplasty, stenting, or bypass surgery, can significantly improve healing rates and limb salvage outcomes for ischemic wounds. Addressing the underlying cause is paramount.
This raises a critical point. Pressure injuries or pressure ulcers are incredibly common, particularly in vulnerable populations like the elderly or immobile. How can they actually be prevented, and what's involved in their complex treatment once they unfortunately develop?
A pressure wound, now often termed pressure injury, is defined as localized damage to the skin and or underlying tissue, usually occurring over a bony prominence, as a result of prolonged, unrelieved pressure or pressure combined with shear, forces parallel to the skin, and bore friction. It should absolutely be considered a largely preventable pathology. Patients at highest risk include those with hip fractures, spinal cord injuries, critical illness requiring immobility, or severe malnutrition cachexia. The most common site is the sacrum, tailbone area, accounting for 28-36% of cases, followed by the heels, 23-30%, and the ischial tuberosities, sitting bone, 17 to 20%. The mechanism involves prolonged weight bearing that elevates tissue pressure above the normal arterial capillary perfusion pressure, around 32 millimeter Hg. This impairs oxygen and nutrient delivery, leading to ischemia and eventually tissue necrosis. Importantly, skin is generally more resistant to pressure effects than underlying muscle and fat. This means you can have significant damage occurring in deeper tissues even when the overlying skin initially appears intact or only mildly reddens, the classic tip of the iceberg phenomenon. Additional factors like friction, rubbing, shear forces, sliding that distorts deeper tissues, excessive moisture leading to maceration, malnutrition, especially protein deficiency, impaired blood supply or lymphatic drainage, socioeconomic factors, and neurologic injury all contribute to the risk. Pressure injuries are staged using a standardized system like the one from the National Pressure Ulcer Advisory Panel, NPUAP. This system defines different levels of tissue damage. Suspected deep tissue injury, SDTI. A purple or maroon localized area of discolored intact skin or a blood-filled blister indicating damage to underlying soft tissue from pressure shear. The full extent of injury may evolve rapidly. Stage 1. Intact skin with non-blanchable redness, erythema. The area doesn't turn white when pressed. Stage 2. Partial thickness loss of dermis, presenting as a shallow open ulcer with a red-pink wound bed, or possibly as an intact or ruptured serum-filled blister. Stage 3. Full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. Slough, dead tissue may be present, and undermining or tunneling can occur. Stage 4. Full thickness tissue loss with exposed bone, tendon, or muscle. Sly or eschar, thick, leathery necrotic tissue may be present. Undermining and tunneling are often present. Unstageable. Full thickness tissue loss where the base of the ulcer is completely obscured by Slyer and/or eschar, making it impossible to determine the true depth unless stage 3 or 4.
So prevention is clearly paramount. But once these injuries develop, what's the multifaceted approach to treatment, especially for those more severe stage 3 and 40 ulcers?
Prevention is indeed the cornerstone. This involves meticulous attention to repositioning the patient frequently, for example, every 2 hours in bed, using specialized pressure redistributing support surfaces, mattresses and wheelchair cushions, to offload pressure from bony prominences, managing moisture, incontinence care, minimizing friction and shear during transfers and repositioning, and optimizing nutrition and hydration. Many early-stage pressure injuries, stage 1 and 2, can heal with consistent pressure offloading, appropriate local wound care, keeping the wound clean and appropriately moist, optimizing the patient's overall nutritional status. Adequate protein intake is crucial. Prealbumin levels are often monitored as a marker, and preventing or treating any infection. Pressure wounds can have a high bacterial load and are often polymicrobial. If infection develops, or especially if bone infection, osteomyelitis, is suspected, common in deep wounds extending to bone, it requires aggressive diagnosis, imaging, possibly bone biopsy, and treatment, often involving surgical debridement of infected bone, ostectomy, and prolonged courses of targeted intravenous antibiotics. Debridement, the removal of non-viable or necrotic tissue, Slough and Escher, is a fundamental principle of treating deeper pressure injuries. This can be achieved through several methods. Sharp debridement, using a scalpel or curette, the fastest method. Mechanical debridement, hardy wet to dry dressings, though less selective now. Enzymatic debridement, using topical collagenase ointments. Or biologic debridement, using sterile medicinal maggots. Antiseptic solutions, like Dakin's solution, dilute bleach, might be used short-term for infected wounds, and enzymatic creams can help promote granulation tissue. Dressing selection is guided by the wound characteristics. Hydrocolloids or occlusive dressings might be used for dry wounds needing moisture, while alginates or absorbent foam dressings are used for wounds with heavy exudate. Negative pressure word vacuum, NPWV therapy, or NPWT, is often very useful for managing these wounds, helping to speed healing, promote wound contraction, decrease exudate and edema, and favor the formation of healthy granulation tissue, often bridging the gap towards surgical closure. For most stage 3 and stage 4 pressure ulcers that don't heal with conservative measures, surgical treatment is often required to achieve definitive closure, particularly over bony prominences like the sacrum or ischium. Surgery typically involves excising the ulcer cavity, draining any associated fluid collections, per se, and eliminating any sinus tracts. After ensuring the patient is medically optimized, nutritionally replete, infection controlled, the wound can be closed. Ostectomy, removing a portion of the underlying prominent bone, is usually performed to reach a healthy bleeding base and reduce the risk of recurrence. A bone biopsy should be taken for culture at this time. After thorough debridement and ensuring hemostasis control of bleeding, a planned local or regional flap is typically used to obliterate the resulting dead space and, importantly, provide durable padded coverage to protect against future wound formation. In cases where muscle spasticity contributes to pressure or shear, a tenotomy, cutting a tendon, might also be performed. Several reliable options for local and regional fasciocutaneous or musculocutaneous flaps exist, depending on the location of the ulcer. Fasciocutaneous flaps, skin and fascia, are often preferred when possible to preserve underlying muscle function, especially in ambulatory patients. Free flaps are rarely necessary for pressure wound closure. Sacral wounds are commonly treated with gluteal rotation flaps or VY advancement flaps. Ischial ulcers, over sitting bones, can often be covered with VY hamstring advancement flaps. Trochanteric pressure wounds, over the hip bone, may be treated with the tensor fasciae lata TFL musculocutaneous flap. Strict adherence to pressure precautions for 2 to 6 weeks after flap surgery is absolutely critical to allow healing and prevent early recurrence.
Okay, let's move specifically to complex extremity reconstruction now, particularly the lower extremity. From the hip down to the foot, this area presents unique and really profound challenges due to its weight-bearing function, critical structures like nerves and vessels, and complex anatomy. What are the main goals when tackling these reconstructions?
You're right, the lower extremity is uniquely challenging. The fundamental goal of lower extremity reconstruction is the restoration of both form and function. Achieving this requires several key components: a stable skeletal framework capable of supporting weight, adequate muscle coverage providing power for motion and joint movement, intact neural supply, especially for protective plantar sensibility, sensation on the sole of the foot, and proprioception, sense of position, adequate blood supply to sustain all the underlying structures, and finally, a stable, durable, soft tissue envelope to cover and protect everything. Reconstruction might be needed for a variety of reasons: severe open fractures with soft tissue loss, defects resulting from sarcoma, cancer resections, chronic radiation wounds, complex non-healing traumatic wounds, extensive diabetic foot ulcers involving bone, chronic venous ulcers, osteomyelitis, bone infection of the tibia, unstable scars causing functional problems, or infections involving vascular grafts in the leg. These cases are often incredibly complex and frequently require a coordinated multidisciplinary surgical team involving orthopedic surgeons, vascular surgeons, and plastic surgeons. Let's focus on soft tissue coverage of traumatic wounds, particularly open fractures. When a fracture breaks the skin, an open fracture, especially when the internal blood supply to the bone, endosteal supply, is interrupted, and the outer lining periosteum is damaged or stripped away, immediate coverage of the exposed bone with healthy vascularized tissue after thorough surgical debridement is crucial for preventing infection and promoting bone healing. The Gustilo classification system is widely used to categorize the severity of open leg fractures based on wound size, degree of soft tissue damage, contamination, and vascular injury. It ranges from Gustilo first, small, clean wound, up to Gustilo third, extensive soft tissue damage, with subtypes IAA, adequate coverage possible, IIB, inadequate coverage, bone exposed, and II, plus an arterial injury requiring repair. This classification helps predict the prognosis and guide treatment.
So how do these Gustilo classifications actually guide the treatment approach for soft tissue coverage?
Generally, Gustilo grade red and most grade 2 fractures can often be closed primarily, directly sutured, after thorough debridement and orthopedic fixation of the bone. However, larger grade 2 and most grade 3 fractures, especially ISIB and IS, almost always require advanced reconstructive techniques, usually involving flap coverage. When flap coverage is needed, it can potentially be done at the same time as the initial fracture stabilization fix and flap, or performed as a secondary procedure a few days later after further debridement if necessary. There's good evidence showing that early coverage of exposed bone, tendons, and neurovascular structures, ideally within the first 72 hours after injury, results in earlier bone healing and reduced infection rates compared to delayed coverage. However, sometimes early definitive reconstruction might be precluded by the patient's other injuries, polytrauma, or severe contamination requiring serial debridements first. Studies have also shown comparable results with closure within the first week or two, as long as the wound is properly managed in the interim. For many years, muscle flaps were considered the workhorse, the primary choice, for covering traumatic lower limb defects, particularly overexposed bone or hardware. Local muscles like the gastrocnemius, calf muscle, and the soleus, deeper calf muscle, are accessible as pedicled flaps for defects in the upper and middle third of the leg. Smaller muscles in the front or side of the leg, like tibialis anterior, extensor digitorum longus, peroneus brevis, can sometimes be used for smaller, more distal defects. However, for larger defects, especially those involving the distal third of the leg, the ankle, and the foot, microvascular free tissue transfers, free flaps, are often preferred. Why? They can provide more bulk if needed. They generally have longer vascular pedicles, offering greater flexibility in reaching the defect and connecting to healthy recipient vessels outside the zone of injury. And importantly, their survival isn't dependent on the potentially compromised blood supply within the injured area itself. It's worth noting, though, that free tissue transfer failure rates are slightly higher in the lower extremity, maybe just below 10%, compared to other body sites, likely due to the higher incidence of associated vascular injuries and underlying pre-existing vascular disease in this patient population.
Are there newer options emerging now? Maybe things that reduce the need for these highly complex free flaps in certain lower extremity trauma cases?
Yes, definitely. Recent advancements in wound care technologies, particularly NPWT, and a growing experience and understanding of local perforator flaps in the leg are creating new and valuable options. As we discussed, negative pressure wound therapy can allow for delayed definitive flap coverage while optimizing the wound bed. And sometimes it can even promote enough granulation tissue formation over exposed structures to allow closure of previously large wounds with simpler methods like skin grafting or local regional flaps. The discovery and refinement of versatile local perforator flaps, based on those septicutaneous or musculocutaneous perforators, and the increased, more reliable use of traditional local fasciocutaneous flaps, like the reverse sural artery flap or keystone design flaps, have also certainly decreased the absolute need for free microvascular transfers in some cases. The advantages of shifting towards these local regional options when feasible include shorter operating times for often critically ill trauma patients and eliminating the need for anastomosis to a major leg artery, which might be injured, diseased, or simply unavailable in some traumatic scenarios. In complex injuries involving loss of both bone and soft tissue, skeletal reconstruction options include using autogenous bone grafts from the patient's own hip, for example, vascularized bone transfer, like a free fibula flap which brings its own blood supply, or using the Ilizarov technique, external fixation with gradual bone transport. Bone grafting procedures are generally delayed for about 6 weeks after the soft tissue reconstruction is stable and healed. The size and location of the bone defect determine the optimal bone graft technique, with vascularized procedures generally preferred for larger defects, typically 6 to 8 centimeters. An alternative approach is immediate, one-stage reconstruction of both the bone and soft tissue defect using an osteocutaneous free tissue transfer, like a fibula flap harvested with an overlying skin paddle.
This inevitably raises a really difficult question. Given the severity and complexity of some of these lower extremity injuries, particularly those Gustilo-Ice types with vascular damage, when is limb salvage perhaps not the best option? When is amputation considered the more appropriate path for a patient's long-term function and quality of life?
That's a profoundly difficult decision, and there are indeed relative contraindications to attempting salvage of a severely mangled lower extremity, especially a Gustilo-grade Isaac injury. Now, a critical factor, often considered a strong relative contraindication, is the disruption of the sciatic nerve, or more specifically, the posterior tibial nerve branch. Laceration of the posterior tibial nerve results in an insensate plantar surface loss of protective sensation on the sole of the foot. Experience has shown this predictably leads to recurrent ulceration, infection, and osteomyelitis down the line, making a non-functional insensate foot a significant liability rather than an asset.
So nerve function is key. What else influences that decision?
Other considerations include the presence of severe, uncontrolled infection or massive contamination, multi-level severe injury involving multiple joints, prolonged ischemia time, typically longer than 6 hours of warm ischemia, significantly worsens outcomes, and the patient's overall medical condition and ability to tolerate multiple complex surgeries and extensive rehabilitation. Pre-existing severe peripheral vascular disease can also heavily influence the decision. While various scoring systems, like the Mangled Extremity Severity Score, MECSS, have been developed to try and aid decision-making, studies have generally shown they tend to be better at identifying patients with good salvage potential rather than definitively indicating who needs an amputation. They should be used as a tool, but not be the sole criterion. The decision requires experienced clinical judgment and a thorough discussion with the patient and family about realistic functional expectations. Replantation of completely severed lower limb in adult is rarely performed. This is primarily due to the extreme difficulty, often impossibility, of restoring meaningful neurologic function, both motor and sensory, to the foot. A non-functional or marginally functional salvaged lower extremity that is painful, unstable, or prone to breakdown is often considered a greater long-term liability than a well-fitting prosthetic limb, which can allow for high-level function, including running and sports in many cases. Absolute contraindications to replantation typically include older age, significant pre-existing health problems, severe multi-level crush injury resulting in likely knee or ankle immobility, and warm ischemia time exceeding 6 hours. Let's look briefly at specific reconstruction areas within the lower extremity and some common approaches. For soft tissue reconstruction in the groin and thigh, defects here are commonly managed with local flaps due to the generally high vascularity and availability of local soft tissue and muscles in this region. The groin, however, is also a common site for infections involving prosthetic vascular grafts used for peripheral artery disease. Muscle flaps are considered the mainstay for managing these challenging vascular graft infections, as healthy, well-vascularized muscle can help increase tissue oxygen tension, augment antibiotic delivery to the area, and importantly, eliminate dead space around the graft. Several muscle flaps are useful for covering exposed femoral vessels in the groin, including the sartorius, gracilis, and rectus femoris, or even bringing down the rectus abdominis muscle from the abdomen, VRAM flap. The sartorius muscle is often considered a first-line treatment due to its proximity, relative expendability, its function is largely taken over by other muscles, and ease of elevation. It originates on the anterior superior iliac spine, hip bone, and has a segmental blood supply, allowing it to be mobilized based on its upper pedicles to cover the femoral vessels. Defects resulting from oncologic surgery, cancer removal in the thigh and groin, present distinct challenges, often involving wide resection margins and frequently requiring adjuvant radiation therapy, leading to a higher incidence of wound healing complications like infection and adhesions. For these large, often irradiated defects, flap reconstruction is almost always necessary. Local options include muscle flaps like gracilis, tensor fasciae lata, vastus lateralis, or fasciocutaneous flaps, medial thigh flap, lateral posterior thigh flap, anterior lateral thigh flap. If these local options are unavailable or compromised by radiation, distant pedicled flaps like the VRAM or free flaps are required. Moving down to soft tissue coverage of the knee, leg, and foot. Wounds around the knee can result from trauma, tumor extirpation, or exposure and infection of total knee replacement prostheses, all requiring durable soft tissue coverage to protect the joint or implant. For the knee itself and the proximal third of the leg, a pedicled, medial, or lateral gastrocnemius muscle flap based on the sural artery branches is often the preferred choice. One head of the gastrocnemius can usually be detached and transposed without significantly impairing ankle function. The medial head is typically larger and has a longer reach, making it often preferred. If this option isn't feasible or fails, free tissue transfer, using flaps like the rectus abdominis or latissimus dorsi, offers high salvage rates for complex knee wounds. Options for soft tissue coverage further down the leg are largely determined by the defect's location relative to the tibia and the availability of local tissues. Proximal tibia, gastrocnemius flap or free tissue transfer. Middle tibia, soleus muscle flap often requires skin grafting over it, possibly gastrocnemius or smaller local muscle flaps, extensor digitorum longus, tibialis anterior. Local fasciocutaneous options like keystone flaps or propeller flaps, perforator-based, are increasingly used. Free tissue transfer remains an option for large defects. Distal tibia. This area is more challenging. Local muscle options are limited. Peroneus brevis, extensor brevis, maybe a distally based soleus flap, though reliability varies. Distally based fasciocutaneous flaps like the reversed sural artery flap or lateral supramalleolar flap are important options. The dorsalis pedis fasciocutaneous flap from the top of the foot can sometimes be used. Free tissue transfer is often required for significant defects. Foot. Local intrinsic foot muscles like flexor digitorum brevis, abductor hallucis, abductor digiti minimi can cover small defects on the sole. Regional flaps like the reverse sural flap, medial plantar artery flap from the arch, or lateral calcaneal artery flap from the heel can cover larger areas. Simple VY advancement flaps can close some heel defects. Free tissue transfer is necessary for extensive foot defects. As you can see, local muscle flaps become less reliable and available for wounds in the distal third of the leg due to their limited reach. Except for the soleus and gastrocnemius, the local muscles on the lower leg are relatively small and only cover limited defects. The distal leg, ankle, and foot are particularly challenging areas for reconstruction. The skin elasticity is poor, bone is very close to the surface, subcutaneous, edema is common, there's little muscle bulk, but many important tendinous structures which don't support skin grafts well. The foot and ankle in particular require especially durable integument skin coverage because of the constant friction and shear forces encountered during walking and wearing footwear. Critically, if transfer tissue is insensate, lacks feeling, it carries a significant risk of breakdown and ulceration over time. Therefore, for larger distal lower extremity defects, reconstruction often relies heavily on free tissue transfer. Careful assessment of the patient's vascular status and selection of appropriate recipient vessels are key planning steps. Guidelines generally recommend performing microvascular anastomoses to healthy vessels located outside the immediate zone of injury whenever possible. Free tissue transfer remains the gold standard, the best option, for large defects, complex wounds involving crush injuries, which damage local blood supply, and situations where vascularized bone transfer is also desirable. For example, using free fibula flaps with attached skin petals for combined bone and soft tissue deficits. However, as mentioned before, our advanced understanding of vascular territories, angiosomes, and perforator anatomy, perforasomes, has significantly expanded the options for local and regional flaps. Highly versatile perforator flaps can now allow successful soft tissue reconstruction without requiring microvascular anastomosis in many cases, providing adequate coverage, sometimes comparable to free tissue transfer, although they often require skin grafting of the donor site. The main limitations of these local flap options currently relate to their potential size limits, the surgeon's experience and familiarity with the techniques, and our still evolving complete understanding of all the relevant vascular territories. For the largest and most complex lower leg soft tissue defects, free tissue transfer currently remains the standard against which other techniques are measured.
Wow. What an absolutely incredible deep dive into the world of plastic surgery. It's just staggering. From the incredibly detailed, almost microscopic work of supermicrosurgery on tiny vessels, enabling things like that freestyle flap, to get the perfect tissue match all the way to the broad strokes of body contouring after massive weight loss, completely reshaping silhouettes. And the profound impact on lives, from correcting congenital conditions like cleft lip and palate right at the start of life, to groundbreaking procedures like facial transplants offering new hope after devastating injury. This field is truly about so much more than just what meets the eye initially. It really is about restoring a sense of self, identity, and crucial function.
Absolutely. Plastic surgery is a field that continues to evolve dynamically, constantly developing new approaches and refining existing ones for the care of people with both congenital and acquired deformities. And it's interesting, with therapeutic advances in other areas of medicine and surgery leading to longer survival rates or new types of problems, new and complex reconstructive challenges continually emerge that demand novel techniques from plastic surgeons, constantly pushing the boundaries of what's possible.
So what does this all really mean for the patient, for the future of medicine? It means plastic surgeons are perpetually challenged by these incredibly difficult clinical problems. They're always looking for innovative ways to treat life-threatening and limb-threatening issues, but simultaneously, always striving to meticulously restore form and function, helping people regain their lives, their identities, their confidence, their ability to interact with the world.
Exactly. The innovations we've explored today, from that philosophical shift embodied by the reconstructive elevator, prioritizing the best outcome first, to the emergence of powerful new techniques like perforator flaps, supermicrosurgery, and even things like fat grafting, which, despite needing more research, may truly revolutionize clinical practice in certain areas. These are just the beginning, or perhaps the current state of the art. The future, looking ahead towards advancements in tissue engineering, perhaps gene therapy influencing healing, and ongoing stem cell work, promises to change the landscape of reconstruction in ways we probably can't even fully foresee right now. The search continues relentlessly for the most reliable, the most durable, and the most aesthetically pleasing ways to, as the pioneering Italian surgeon Gaspar Tagliacozzi famously wrote way back in 1597, restore, repair, and make whole those parts, which fortune has taken away.
A truly inspiring vision that resonates across centuries. We hope this deep dive has given you, our listeners, a renewed appreciation for the incredible artistry, the deep scientific knowledge, and the relentless innovation that lies at the very heart of modern plastic and reconstructive surgery. Thank you so much for joining us on the deep dive. Until next time, keep digging for knowledge.